hello, everyone. Once more, my name is David Armstrong. I welcome the live audience here in person, but also our remote audience. And welcome to the 2023 Health Workforce Research Symposium, addressing health workforce shortages now and in the future. We have what I think is a very exciting program today, but I would like to introduce the Director of the National Center for Health Workforce Analysis, Dr. Michelle Washko. And I believe Dr. Michelle Washko is going to tell us a little bit more about the Health Workforce Research Center program. Michelle?
Thank you, David. Good morning. As David said, I am Michelle. I am the Director of the National Center for Health Workforce Analysis. For over a decade, HRSA has sponsored health workforce research centers in the U.S., which are essential to helping the public understand this labor force in our country. And I've been proud to be a part of that program since the beginning. These centers conduct and disseminate rigorous research that reflects past, current, and potential futures for the workforce in the health sector. At the moment, we support centers in the areas of oral health, allied health, behavioral health, public health, and more, all of which you're going to hear about today. But additionally, because of the importance of these centers and the work they produce, and because that work has become so widely known, our partners in the CDC and SAMHSA also financially support them. Taken together, these centers are seen as a force of nationally recognized experts who can provide essential information and assistance to local, regional, state, and federal partners. As we all know, COVID-19 brought a large spotlight to the healthcare workforce, but specifically their work. And while we're no longer in an active pandemic, the world is still grappling with its aftershocks, and that certainly includes all of us focused on the healthcare workforce. These health workforce research centers and their scientists continue to produce critical and timely information for us all. In fact, in the past year, they produced scores of articles, policy briefs, they conducted public webinars, podcasts, they presented at conferences, meetings, and even briefed legislative branches at the state and the federal level. We in HHS thank every single one of them for their myriad of contributions over the past decade to the field as they continue to enhance our understanding of this critical component of the U.S. healthcare system. I'm very much looking forward to today's discussion, as I'm sure we all are, and I thank you all for participating. Let's get started.
Good morning, everyone. I'm pleased to be here and kick off the first panel in our deep dive on health workforce today. This is a topic that we're starting off with on career pathways that is so central to ensuring that we have a workforce that can achieve health workforce equity, which is the concept that we at the Mullen Institute like to refer to as the overlap between health workforce and health equity, to ensure that our vision is that the health workforce has the competencies, opportunities, and courage to ensure that everyone can achieve their full health potential. And this is such front and center work we're doing right now, given some of the challenges that Michelle pointed out earlier. When we think about, particularly around career pathways, where there are a lot of health professions that aren't as valued as they could be, low wages, limited opportunities in career pathways. We also face a major roadblock right now with the recent Supreme Court decision around affirmative action, which is also going to make it more challenging to ensure we have a diverse workforce, which is so central to advancing health equity. And so, while we have all these challenges in what Fitzhugh Mullen used to refer to as the health workforce battleground, I think right now we need to not only identify and make sure we understand what those problems are, which you'll hear a little bit about today, this morning, as well as find some new ideas for how we might address some of those challenges, as we'll see through some of the presentations as well. So we're going to start off today with Bianca Frogner, who's going to be talking about career pathways for pharmacists and clinical lab workforce. And Dr. Frogner is a well-known health workforce researcher who is the head of not one, but two health workforce centers, one on allied health professions and another on health equity. And then she's going to be followed by Lisa de Zerden, who is going to be talking about using a new data set that I had never really heard of, the National Survey of College Graduates, to look at pathways for getting people to advance their career from a bachelor's to go on to pursue a master's degree. And Dr. de Zerden has really been a longstanding workforce researcher in social work and is the deputy director of the Behavioral Health Workforce Research Center. And she's going to be followed by Simona Surdu, who is a physician and a doctoral researcher in health equity who's done work for the NIH and the World Health Organization, and for the past decade has been doing oral health workforce research data. And she's going to be talking about the benefits of having a diverse dental workforce. And then lastly, but certainly not least, we'll have JP Leider, who is really, when you think public health workforce research, that's who you think of as JP. And he's going to be presenting today on a new method for helping people to identify and find public health workforce graduates. So I think we've got an exciting lineup today. I'm going to encourage everyone to keep to their 15 minutes at the most, because we've really got a lot to cover today. And I'll just sort of wave my phone at you if it looks like you're running over time. So that means wrap up. Okay. We'll start off with Bianca.
Okay, thank you so much for having me here today. It's so exciting to see all of you here in the room, and thank you to everybody online who's joining us today. I realized one thing I did not ask about is how to forward these slides here, so we'll all work on this together. So, so I'm going to talk about two different workforces today, the pharmacy workforce and the clinical lab workforce. They seem like they're fairly different groups, but there are a lot of similarities, but yet some interesting challenges that each one will be facing. So I'm going to talk about each one of them separately, talking about some studies that we've been doing for each of these workforces and try to bring it back together at the end. Oh, okay, found the clicker. Okay, and everything I'm presenting here today is funded by HRSA. Thank you so much. But of course, none of what we're saying today is an official view of HRSA. So I'm going to talk about the pharmacy workforce. And the pharmacy workforce, for many of you, probably the first group that comes to mind are pharmacists. We also have your pharmacy technicians, and we have other support staff in that workforce. We've done a number of studies on the pharmacy workforce over the course of the years through our Allied Health Center program. And I'm going to present one study in particular that we recently completed, and we have a couple more underway, and I'll talk about how those are connected to some of the work that we recently completed. So I'm going to talk a little bit about community pharmacy. And community pharmacies, there's over 60,000 of them in the US, and they're some of the most accessible sites in the US. And it turns out that individuals actually more commonly go to a pharmacy, a community pharmacy, than they do any other, than their primary care providers. So these are touch points and an opportunity for patients to be engaged. However, many people think about going to the pharmacy as a place that you get your medications. But there are a number of services that can be provided in a pharmacy setting, such as doing medication optimization, care management, and there can be some educational opportunities there too. And during the pandemic, the pharmacy certainly became a very clear place where patients needed and were engaging with some providers, in part because they were trying to figure out how did they continue to get the medications they needed during this crisis. And as the pandemic has rolled on, these were places that we could actually do vaccinations. And so it raised some questions as to what actually really happened in the community pharmacy setting during the pandemic. And so we did a convenience sample of community pharmacists, leaders, and other pharmacy association leaders across the country to better understand how they responded and were responding to the pandemic, because we were conducting interviews during 2022, where, if you all remember, it's not that long ago, is that we were still very much in the kind of coming out, kind of figuring out what the next steps are during the pandemic. And so we did a set of semi-structured interviews and did some rapid content analysis of those interview notes. Out of the study, we came out with 4 themes, and I apologize that theme 1 may be a little bit harder for those in the room to read, and I'm going to highlight 2 of the themes in particular and some of the findings there, which highlight a little bit more of the workforce challenges that the community pharmacy settings faced. So one of the themes that we came across in this study is that patient care was happening in these community pharmacies, where it was really a response to trying to meet the needs that were coming and arising during the pandemic. And another theme that we saw was that pharmacists have had a history of doing immunizations, and that really started to be coming more into the forefront of an activity that they need to do, and that there were opportunities to really expand the scope of the work of both pharmacists and pharmacy technicians during the pandemic. And I'll go into that a little bit more in detail. Now, there have been shortages, and if you read the news, we still currently struggle with pharmacy shortages. I think recently Walgreens has, there's been some headlines about Walgreens experiencing some walkouts of pharmacists and pharmacy technicians. And this is a constant theme, is that there have been these shortages, and in part it's because there's been an increase in workload due to the COVID response, and all of this is contributing to burnout. Another theme that arose is that in order to think into the future, we need to figure out how do we capture all of what we learned during this pandemic and build that into future emergency preparedness and response. So just to dive a little bit more into one of the themes, one of the themes that we had around the pharmacist's history in terms of doing immunization and how scope of practice expansions were accelerating during this pandemic. We have a couple example quotes here for you to take a read at. But basically, the quote on the left-hand side of the slide suggests that the vaccination role that pharmacists were playing were really accelerating this during this point in time. So it's not that they weren't doing it before, but now this was an opportunity to leverage these points of access where patients were going regularly and capturing them and trying to encourage them to get the vaccine. Now, this really added a significant load to the pharmacist, so there were opportunities here to look at the pharmacy technician and figure out how to leverage their skill set to get them trained to help and do some COVID vaccinations. And in a lot of ways, it sounds like pharmacy technicians were a critical part of this workforce in terms of making this a reality. One of the other themes diving a little bit more into is that as I mentioned, is that we certainly have seen shortages and concerns about shortages of pharmacy technicians, which basically means we have to dive more into the word shortage, and we'll certainly have more of a discussion around those words. That's not just as simple as saying that there's just a lack of number of people, but that this is about also the capacity of the workforce to take on all the extra workload that kind of came about, combined with the fact that there was a lot of turnover in the pharmacy technician workforce, and has been a lot of turnover in this workforce, which is adding a lot of stress, and the pandemic certainly added to that as we were asking them to do more things. So while they can do some, were able to pick up some activities around vaccinations, this was adding to a workload that they already had that was already fairly high. So this adds stress and contributes to burnout and stressful environment for these workers that makes them think about this not necessarily being a place that they want to pursue a career. And the way payment is in pharmacies is it's still very focused on dispensing and paying for the dispensing of prescription drugs, rather than paying for all the services that pharmacists are trained to do. And so this made it difficult because pharmacists were having to figure out how to make sure that revenue was coming in by dispensing and providing the medications needed for the patient population, while also doing all the other activities that they are trained to do, such as providing that care management and providing that patient education. But they really aren't being reimbursed in a way that makes that a meaningful and sustainable source of revenue. And so it creates some conflict for pharmacists as they try to think about what is their career here. They have been trained so much. How do they leverage all of their training in a way that also meets the needs of the environments in which they're working in, which requires them to also bring in revenue into these different environments to survive? So in terms of takeaways for career paths that we found from this study in particular is that we did see that pharmacy technicians, that their scope of practice have expanded during the pandemic, and that they play a very important supportive role to pharmacists. But there are limited career pathway opportunities, and the stressful work environment makes it very difficult for workers to stay here. We have some ongoing study that we're submitting now for review, looking more deeply at pharmacy technicians and how to make these more professionalized careers. And try to figure out how they can be a little bit more independent from what the pharmacist does, and really try to make that more of a clear career pathway. Pharmacist scope of practice, they also expanded during this course in time during the pandemic, but because of reimbursement and some other challenges around policies, we are seeing it challenging for pharmacists to feel that, that they can really do all of what they're trained to do. And this is having a direct consequence where a lot of pharmacy schools are seeing a real drop in enrollment. While many other health professional schools have seen an increase in enrollment, we are seeing a decline in the student enrollment in pharmacy schools. And so we have a study that's going to be, that's ongoing now, that's trying to better understand and unpack what's happening there, because some of what we're hearing in the media is influencing the choices of people in their early careers, as well as the reputations that's coming out from word of mouth by pharmacists as they reflect on their career path during these last few years. All right, so I'm going to turn to the clinical lab workforce. And this work, I want to acknowledge my colleagues here in the room, the American Society of Clinical Pathology, who has been a fantastic collaborator with us on some earlier work that it was a precursor to the work that I'm talking about today, and they continue to be a partner in this work that I'll talk about. And again, this is one of, I'm going to talk a little bit about some of the ongoing work that we're doing with the clinical lab workforce under our Allied Health Center. And just a little bit of background, we have about almost 500,000 of people who are probably in this workforce, and that's probably an undercount based on how we classify these workers. And the pandemic, again, brought this workforce into the spotlight. And there are many, many jobs and many job titles in this workforce, but it's really hard to really unpack some of the career pathways in this workforce. And this slide, I don't expect you to digest it all, but the idea is that there are many different occupations, but many different routes to get to those occupations. And those occupations can range in terms of the requirements, from having as little as about 1 year of postgraduate education to up to a doctoral level education. And you can get that, you can find a career in health, clinical lab jobs via both a formal educational process as well as certificates. And so in our study, in this one here, we're trying to better understand how do people find their way to these clinical lab jobs, and what are the things that help them find their way here, and what are some plans in the future for some of these workers, and those barriers to achieving those goals. So I'm just going to show a few key findings here because the work is still very much in process. We had a survey that we fielded to multiple occupations in the clinical lab workforce, and we used this conceptual model to help us kind of unpack different elements of the career pathway, because there's many, many parts to people kind of finding their way into a career that starts way before they ever even apply for school. So we, again, targeted multiple professions here. We developed a survey, and in our initial analysis, and what I'm talking about today, is I'm going to focus on a group called medical lab scientists. And these are relatively well-trained individuals. They have multiple years of postgraduate education. But it's a field that it's clear that there's a lot of different pathways into this occupation. And so we did a data collection process earlier this year, and we have about 1,500 responses from this survey. So in terms of how people found this career, one of the most dominant motivations for finding their way into, or exposures to finding a career here, was via a family or a friend. So that means that word of mouth currently plays such an important role to get people into these jobs. It's because you see it with a friend or a family member tells you about the job, then a student has some better understanding about what this career is about. A college counselor or an advisor is a close second, and people can choose multiple options here. But again, people having a direct touch point by somebody who identifies these people as being potential candidates for these careers is how people are finding their way here. There are some other variety of ways by which people find their way to a career, but really having that personal touch point seems to be a key one. In terms of one way people find their way to their job, they do generally feel fairly well satisfied with their current job once they find their way into these jobs, which is really encouraging. And so what you're seeing here is mostly the dark blue and lighter blue suggest that people are agreeing with various statements about whether or not their jobs provide them with a schedule that they prefer and that they have the ability to work at the full extent of their education. And they're mostly agreeing with these statements. The only place that they're feeling that a little less satisfaction is around whether or not they feel like their current work environment is adequately staffed. in terms of their current job environment, and similarly, you'll see some of the same kind of trends here, is that people feel, again, fairly satisfied with their job. They enjoy their work. They feel like they're accomplishing things. But again, at the end, the area that we're seeing a little bit more deficiency is that their institution is not showing appreciation for them. And these are real contributors to burnout. And what we really took away from this work and are trying to unpack a little bit more is that clinical lab jobs are fairly invisible to the public. I mean, think about how many of your own kids or people that you know in your life say, I want to be a medical lab scientist someday. I don't know. That's not one that I hear very often in conversation, but there are many very, potentially very rewarding jobs here. However, we need to make sure that these are jobs that are well recognized by both leadership in the healthcare industry and that they are supported by management, and that we don't add strain and lose these workers who feel the pressures of the staffing shortages around them. So some final thoughts to wrap this up. Both the pharmacy workforce and the clinical lab workforce became very visible during the pandemic, and both of the groups also saw expanded scope of practice. I didn't talk about that as much for the clinical lab workforce, but we certainly saw a growth in terms of their ability to provide services outside of just the typical lab environment, such as helping to do COVID tests. But the steps to the pharmacy jobs are a little bit more clear than it is for the clinical lab workforce. However, for both of these workforces, there's a real lack of clarity about how one moves from one occupation to another, partly because of the lack of visibility, partly there's a lot of assumptions. There's a lot of assumptions that pharmacy technicians can just one day become pharmacists. Well, that's a fairly big jump in terms of educational process and the amount of investment for school, so we need to make sure that we don't lose these folks because they don't see a career pathway. And as I mentioned earlier, we are going to look into some of the declining student enrollment in pharmacy schools. And for clinical lab jobs, we're just starting to aim at working together with ASCP to help map out all the many pathways to these jobs. Now, I certainly want to acknowledge the wonderful teams of people who have been part of these studies, including Jenny Bocci at the School of Pharmacy at UW, who's helped to lead a lot of our pharmacy work, and Sue Skillman, who's the Senior Deputy Director at the Center for Health Workforce Studies, who also has been very helpful in shaping both of these studies, and again, our colleagues at ASCP. So thank you so much.
Great, thank you so much. My name is Lisa de Saxe-Zerden, and I am an associate professor at the UNC, the University of North Carolina, Chapel Hill School of Social Work, and I'm also the deputy director for the new UNC Behavioral Health Workforce Research Center. I'm very happy to be here. I'm a proud social work researcher and relatively new to health services research, and it seems quite unfair to have to follow Dr. Bianca Frogner because she's someone whose work has really helped us advance how we think about health services research. Today I'm going to talk to you about diversifying the behavioral health workforce research, and I'll talk about how complex the behavioral health workforce research is, because we include everything from peers to psychiatry, master's level providers, and everything in between. So it's a really rich and complicated workforce. I'm going to focus today on social work, and want to just acknowledge, I wanted to acknowledge our team who was on the first slide, and then also Dr. Lombardi, who is the director of the Behavioral Health Workforce Research Center and is a huge collaborator. UNC Chapel Hill is relatively, the Behavioral Health Workforce Center is relatively new to UNC, although we have the mentorship and guidance of Dr. Erin Fraher, and are really proud to be one of the 9 federally funded workforce centers. We are the only center that is focused particularly on behavioral health, and it's a cooperative agreement for 5 years with SAMHSA and HRSA. Our goal is to really think about how we can improve behavioral health by doing research that's going to strengthen these disparities that really make it difficult for people to access treatments, to get the care that they need, and quality care that they need. A funding disclosure to acknowledge SAMHSA and HRSA, and to note also that the content that you hear today is not necessarily an endorsement, but it's our findings alone. In the presentation today, we're going to talk about exploring the graduate pathway to social work education, from a BSW, a bachelor's in social work, to obtaining a master's in social work, and MSW. And you'll hear me talk about that. I'll give a very quick snapshot on the behavioral health workforce and the diversity within it. We'll talk about an overview of social work education in case you're not familiar with this workforce. And I'll talk about this one-year project that we have finalized and is now out in press. So if you have questions or want more details on the methods, it's available. We'll talk about the policy implications and what this means for helping to grow and sustain the behavioral health workforce in social work. We'll do this all in the next 11 minutes. So we all know and have heard already this morning about the behavioral health crisis, where far more people have needs than what is available. Rates of overdose, suicidality, loneliness, depression. You can just think about your own personal lives, but across the life course, we know that behavioral health is at a real crisis point. Not only are behavioral health needs on a rise, but we also know that there is a shortage and a distribution issue of where people can get behavioral health care. So when we're thinking about how to address this behavioral health crisis, we really have to understand who comprises this workforce. Who are we talking about when we're talking about a behavioral health workforce? What are pathways into the behavioral health profession? Because there are many, and we lump them kind of all together, but they're so distinct. What are the educational barriers and pathways? And then also, what strategies do we have to sustain and retain and attract people into the behavioral health workforce? So not only are these behavioral health issues on a rise, not only is there a distribution issue in terms of where behavioral health people are, but really thinking about how do we provide a diverse workforce so we can create concordant care where there is a match between providers and consumers. And that has shown to be very positively impact the outcome of care. We know that concordant care is good for the healthcare team, and it's really good for the patient and families. Increased satisfaction, increased adherence to treatment plans, and cost-effective utilization of the healthcare system. So we have now this kind of trifecta of a shortage, increasing rise, wanting to diversify the workforce. It's a lot of inputs into a very complex problem. So what we wanted to think about was just generally giving you a snapshot of the behavioral health workforce. And this work comes out of the team from George Washington, so we're very grateful for their tracker. But when you think about the US Census Bureau population, and you think about who comprises the behavioral health workforce, you can see a snapshot here. And you can see that for social work, we have a fairly robust behavioral health workforce reflecting diversity, which is not what you see across some of the other professions here. Just noting here that we have more representation among Black social workers who are identified here compared to some other groups that you see lower representation. So while we have examples of workforce concordance and we have career ladder pathways and evidence that we can look at across the health professions, there's been very little done on what this means for behavioral health and what this means for social work pathways in particular. Social workers, if you're not familiar with this type of workforce, is one of the largest groups of behavioral health providers in the country. I'm not going to give you a specific number because we don't have a national data source and they vary quite widely, as some of you know. But what you should know about social work is that we have been in the healthcare space for more than 120 years, and we are considered in some ways to some health workforce researchers an emerging or new workforce, but we're not. And we know that the projections of social work have seen a steady increase over the last 10 years and continue in the next 10 years, about 12% expected job growth compared to other professions. And we know that those in the health and behavioral health sector particularly are where we are expecting to see those largest growths. So when we're thinking about this pathway, just so you know, bachelor's in social work is not a requirement for a master's in social work. We attract all types of undergraduate degrees, but it is one pathway that we can look at, and it's an important pathway because the MSW is considered the terminal practice degree. When we think about the social work workforce, we can think about statistics we have from the Council on Social Work Education. And we're lucky to have the president of CSWE here with us today. But when we think about data from 2019 to 2020, we know that more than 50% of those BSW graduates represented underrepresented minorities. When we think about the nearly 32,000 MSW graduates, we know that about 18% of those were comprised of folks who were African American. So clearly we're losing some folks in this pathway from BSW to MSW. And we have to think about how to do this if we're seeing a steady growth in the profession. So I don't have exact national, I have national trends that can talk to you about loan debt and what that burden is for students. And the first bullet is not specific to social work. So just nationally, we know that 4 years post-graduation, nearly 50% of students who identified as Black owed on average 12.5% more than what they had borrowed, compared to 80% of white identifying students who owed 12% less. So we already see that this is going to impact educational opportunities and future earnings and ability to kind of start your life, your adult life after graduate school. Now for the second bullet, we see that social work loan debt is not broken up by race and ethnicity, but what we do know is that the average loan debt associated with receiving social work education has increased from about 32,000 to almost 50,000 from 2010 to 2020. And it's important to put this in the context of what the median salary is for a health social worker. And you can see that this can be quite a problem attracting people into the profession. Besides race and loan debt, we know that there are other correlates that we should think about along this pathway: community college attendance, do you have an associate's degree, the type of institution, a private, a public, the cost of that experience, and then, of course, life course and age of receiving your degree. So with all this in mind, I can bring you now to our research study, which really wanted to understand if students of minoritized backgrounds and identities were less likely to transition from a BSW to an MSW. To what extent did the characteristics of that institution, their loan amounts, the type of institution, college, community college attendance, was that associated with the odds of obtaining an MSW after a BSW? And then what are the associations between educational characteristics and the odds of obtaining that degree? The data source that you had heard about briefly is the National Survey of College Graduates. This is a nationally representative survey. We used 2019 data, but it has been used primarily in the STEM fields to understand the trajectory for folks to go into the physical sciences. And to our knowledge, it has not been used for behavioral health, and it certainly has not been used for social work. So there's a pretty complex stratified sampling design and weighting that is done for this nationally representative sample. But in our study, we were looking at 538 participants, and this is reflective of more than 635,000 people. When you think about what the weighted demographics are here, you see primarily female. You'll see that 60% identified as non-Hispanic white, and then it goes down there. We'll note up front before we get into our findings that because of the study's relatively small analytic sample size, we recognize up front that we are hindered in our ability to go more granularly into the nuances of different races and ethnicities. We see how small it is between Asian, multiracial, American Indian, Alaskan Native, and so that's a limitation that we admit, and it's a limitation of the data source. And then we also can think about the educational characteristics of this sample. Almost 50% had $10,000 or more in undergraduate loans, so starting that obtaining of an MSW already in debt. We see that 68% attended a public institution, and this is was quite striking to us. 57% had attended community college, which is part of the pathway we didn't even put into our research questions necessarily, but is clearly a big indicator. And then thinking about that associate's degree. So we have our descriptive analysis that were run on all of the variables, and then we ran a logistic regression to assess this association between the odds of obtaining our MSW degree following that BSW degree, looking at the following correlates. We tested the interaction between race and ethnicity and other substantive variables, and our paper goes into more detail about the methods and plan. But for time's sake, I'm going to keep us moving. When you look at the BSW group only, and then on the other side, the BSW to MSW side, you see that there are similarities, some differences, but there are similarities just based on racial and ethnic composition. The BSW only group has a higher multiracial percentage versus those who obtained the MSW. And then you see white students at 58% for BSW versus 68% who obtained the MSW. Breaking down some of our key findings, I wanted to let you know that racial and ethnic identity alone is not what directly predicts the likelihood of pursuing that MSW degree, but we know it's these educational characteristics that impact, and this interaction is what was so interesting for us. So race, the logistic regression models pertain to this interaction effect rather than that main effect. The model yielded marginally significant interactions between race and ethnic identity, undergraduate loan amounts, and attendance of community college. What we saw was an increase in undergraduate loan amounts were associated with an increased probability of obtaining an MSW degree for white individuals, but not others. We also saw a decreased probability among non-Hispanic Black individuals from obtaining that MSW. And here are some findings that are looking at some of the some important racial differences that were significant. Just for some context, we can see here that 83% of non-Hispanic Black individuals had some amount of undergraduate loan debt compared to 54% of non-Hispanic whites. And you'll see the predicted probability of white graduates was higher for obtaining that MSW as their loan amount went up. So the more loans they took, the more likely they were continuing to go on, which was the reverse effect for our Black students here. You can see this also for those that attended community college. Among those who attended community college, among white students, 29% went on, versus looking at Hispanic students, only 11% went on. So there was some significant differences here, and it's important to note that 82% of respondents attended community college versus 46% of the white. I'm sorry that we only have just a minute or two more to talk about these policy implications, because this is the most important part. What I want to talk about is just some of those policy levers that we can think about in terms of educational pathways. For social work, in order to get loan repayment, for example, or to participate in the National Health Service Corps, you have to be an MSW graduate and you have to be fully licensed. So you have to be at the very end of that pathway in order to benefit from some of those policy mechanisms which can help you get that degree. So that is a really important finding for us to think about. Is there a way to change that timing to offer BSW students more access to loan repayment opportunities to increase their ability to go on? Thinking about community college investments, which I said we knew was something, but we haven't talked about investing in those programs as pathways onto the BSW and so on. Thinking about holistic admissions practices, I know that our school at UNC has done away with the GREs. We know that there's issues with licensure data by race and ethnicity. So thinking about what you can do to look at the whole person, their whole context, and to think about economic vulnerability, not just race and ethnicity, to think about who you're capturing into the profession. So I could say a lot more about this, and as I mentioned, our paper is out now in the Journal of Social Work Research. So I'm happy for you to take a look and learn more about this study. But again, we just hope you'll have a new recognition of social work as a really powerful behavioral health workforce, and that there's so much more we can do to invest in this workforce to contribute to the behavioral health workforce.
Good morning. My name is Simona Surdu, and I'm the Deputy Director of the Oral Health Workforce Research Center. And today I'm going to present on our results from related to the impact of improving gender diversity in dentistry. First, I would like to acknowledge the contributions of my colleagues, our director, Dr. Jean Moore, my colleague present here in the room, Dr. Dikshana Fernando, and Ms. Margaret Langerie, the former co-deputy director of the Oral Health Workforce Research Center. I would like also to acknowledge the support that we received from HRSA. And the content and conclusions of this presentation are those of our center, and they do not necessarily represent positions or policies of SUNY, HRSA, or ADA, which I forgot to mention. We also have the support from the Health Policy Institute at the American Dental Association. So just a very brief introduction. I would like to draw your attention to the participation of females in higher paying health professions, which has increased over the last years. Currently, we have about 38% females in physicians, and about 37% of dentists are also females. So the participation of females in health profession will likely grow as the percentage of female graduates from education programs will either stay at the current rates, which are about 52% in both medical and dental education programs, or will increase or will continue to increase. And also as many older, mainly men, professionals will depart the workforce. So while the reasons for the gender diversification can be attributed to several social and economic factors, the long-term impacts of professional diversification is not well understood. So today's presentation, I will focus on two research studies conducted by our center. Details in terms of description of the study methods as well as the results can be found on two technical reports that are published on our website. And also we publish the results in two peer-reviewed journal articles that can also be found, the links that can be found on our website. So the first study, the Women in Dentistry and Potential Impact on Access to Care for Underserved Communities, had the aim to evaluate the characteristics in terms of dental education and practice patterns of dentists. We also wanted to see if there are any differences by gender and to discuss the potential implications for dental service delivery system. For this study, we used two data sets. The first one from American Dental Association, the master file, which is a very comprehensive database of all US dentists, and includes information on demographics, dental education, and dental practice of dentists. We used this data, we analyzed the data from 2010 to 2016 for this particular project. We also used for this project, again, the ADA data, this time from a survey of dental practice that they conduct annually, which collects information on various characteristics of the private dental practice. So these are private dental dentists that are surveyed annually. Also, this survey collects information in terms of their education and practice, as I mentioned, private practice, about their patients as well. And the next two slides actually are showing the gender diversity in dental workforce as well as in for the dental graduates. Again, for these two slides, we used the ADA data, but we actually looked at the most current data, so beyond the two projects data that I mentioned before. So as you can see from this particular chart, nationwide between 2010 and 2022, the percentage of female dentists increased from about 24% to about 37%, which represent on average a 55% change over the 13-year study period. In terms of changes in gender among dental school graduates, looking at data from 2011 to 2021, we observed an increase of female participation or a female proportion in the graduates from dental schools from 45% to about 52%. We noticed that around 2018, actually there was a parity in gender for the dental graduates. And actually in 2019, the female graduates from the dental school surpassed the male graduates. This chart shows race ethnicity distribution among female dentists and among male dentists, so female dentists in blue and male dentists in pink. Although both male and female dentists were mostly, the majority of female and male dentists was white, non-Hispanic, we do see that actually proportionally more female dentists were Asian, Black and African American, Hispanic, or other race or ethnicity. This chart shows dental profession education and training variation between female dentists and male dentists. As we can see from the chart, female dentists were more likely to be foreign trained. Also, they were more likely to complete a dental residency either in general practice or pediatric dentistry. And the last results chart from this study looks at the provision of dental care by dentist gender and age cohorts. On the left side, it's in terms of patients' age, children, and on the right hand, it's about patients covered by public dental insurance. So we can see from this chart that female dentists were significantly more likely, between 22% to almost to more than 50% more likely to serve children patients compared to male dentists. The left side again of the chart. Also, female dentists were about 30% to 80% more likely to serve patients covered by a public dental insurance compared to their male colleagues. Now a little bit about the second study that is titled "The Income Gap Between Men and Women in Dentistry." This study had an aim to provide an update in terms of income disparities between men and female dentists. Also, we wanted to look at factors that could have an impact on income gap between men and women dentistry, looking in particular to personal factors, family or household factors, as well as employment or practice or work-related factors. For this study, we use the 5-year American Community Survey between 2014 and 2018. And we analyzed the data using linear regression as well as Osaka-Blinder regression decomposition. And now this slide shows the characteristics of dentists from the ACS data. As presented a little bit earlier in terms of the data from the ADA master file, we also see in the ACS data that female dentists were more likely to be racially and ethnically diverse compared to their male colleagues. But in addition, from the ACS data, we could look at other characteristics, and this chart shows that actually female dentists were more likely to be foreign-born and to be bilingual. So this adds another dimension to the diversification of the dental workforce in terms of language and culture. And now the last chart in terms of the results from this study looks at and presents the percentages of income gap between male and female dentists that was explained by the characteristics that we had available from the ACS data. So after adjusting for all the variables that we had available in the ACS data, we found that male dentists earn 22% more than female dentists. Also, as you can see actually from this particular chart, the first column, the first bar in green, we can see that only about 27% of the gender gap can be explained by average differences in the observable characteristics in terms of, again, personal, family, work-related characteristics of male dentists versus female dentists. And also, I would like to draw your attention to personal factors. So we can see that actually the significant personal factors that explain part of the income gap, such as white, non-Hispanic race ethnicity, not being bilingual, or in other words, only speaking English, or having a spouse or a husband or a wife, were actually personal characteristics that were significantly associated with the higher income among male dentists compared to female dentists. And of course, all the other kind of variables related to the employment practice and work-related practice characteristics that we expect they will have some impact on the wage gap. I'm not going to present on these studies, but I still wanted to kind of draw your attention to several other studies that we conducted at the center on postgraduate trainees' challenges and opportunities that are published on our website, since they are on the same kind of theme of education and pathways. And now going back to the two studies that I presented, just a few conclusions and implications. So our research showed that a growing percentage of female participation in the dental workforce actually was accompanied by also a rise in racial and ethnic diversity, language and cultural diversity as well. Also, the female dentists were more likely to serve patients that were covered by public dental insurance, and these results are very important in the light of the fact that more diverse, there is an increase in diversity of patients that need to be served, so having a well-prepared and diverse oral workforce is very important. Also, our research indicated the persistence of income disparities in dentistry. And although both the explained as well as unexplained variation in the income gap are concerning, I think that it's actually the proportion of the gap that is explained by the personal characteristics of the dentist is especially concerning. So I would like to kind of end on the note that although the diversification of the dental workforce is promising, but it's absolutely critical that we address the income disparities in the dental workforce. And just very briefly, some future kind of research directions that we see important is to continue to look at the trends in the diversification of the oral health workforce in order to be able to be proactive in responding to changes in dental practice patterns. Also will be important to look to other models of care, to innovative emerging model of care in dentistry that have the potential to address some of the healthcare needs of the growing and aging US population, including, for example, integration of health services, expanding the scope of practice of dental professionals, and also introducing new dental professionals, for example, dental therapists. Also the use of mobile and portable dentistry or teledentistry, and of course providing work incentives to the dental workforce. And with that, thank you very much, and I will take the questions at the end. Thank you.
All right, so we're going to end session one with some maps. When we talk about the public health workforce, specifically the governmental public health workforce, one of the things that I like to start by saying is that you might think that most people in governmental public health have a public health degree, but that's just not true. About 14% of state and local health department staff have a formal public health degree of any kind at all. And so when you think about creating supply estimates for public health practitioners, and you think about the demand to meet that supply, it's important to think about, yes, the schools and programs connecting to state and local health departments, but also about all of the other kinds of degrees. So today, when we think about how do we create estimates for supply and all these nice maps I'm going to show you, it's going to focus on schools and programs, but then we'll also think more broadly. So that's where we're going to start. How do we think about supply? How do we think about deficit? And how do we think about schools and programs, but also more broadly? And here's the challenge that we're going to face. I'm just going to dive right in. We've got state health agencies in the yellow, we've got local health departments in the blue, and we've got, schools and programs of public health in the blue, and we've got local health departments in the red, just all over. All over the country, we have this complex interrelationship. And in some states there are more, some states there are fewer. And I think for those who have connections between schools and health departments, schools and hospitals or healthcare organizations, one of the things that's true about pathway programs, often you have kind of champions that make these internships, champions that create these pathway programs, and if you don't have structures in place, it's hard for these pathways to persevere and to hold. If you don't have the structures, if you don't have the infrastructure, it's hard to have supply. So the reason I'm kind of diving right in is because I want to spend time talking about how do you create these estimates. So I'm going to start with Minnesota, because how do we talk about the whole country at once? I think that's a little tough. So just in Minnesota, we've got one state health agency. We've got a number of schools and programs of public health, and then we've got 74 health departments. How do we think about how a school or a program could supply health departments, right? You've got, in one area, potentially lots of schools, or lots of programs in this case, because we have one school of public health in our state, potentially supplying a lot of different spots. So how do we model that? Well, I'm going to talk about how we do that visually. So you create a lot of these little buffers, right? Little circles, you pop them on a spot, and you start to just think about what overlaps with which. And in rural jurisdictions, you could imagine that there's going to be a lot of zones where there's nothing. In Minnesota, we have a lot of rural jurisdictions. So maybe you have to expand the buffers, because as many of us who do health workforce research know, it's not exclusively the case that where you go to school is where you're going to end up working. But on average, it's within a pretty close zone for many people. So in urban areas, you're likely to have much of your graduating class kind of work around there. And in the Midwest, that's pretty true. In the Northeast or the Pacific Northwest or the West Coast, maybe there's more geographic variability. One of the other things you can think about doing is you can kind of repeat this buffer for similar kinds of programs. So if we're not just thinking about schools of public health, we could start to think about other kinds of health programs for which there are many more. Nursing programs or allied health programs, which is kind of a family that's maybe not as descriptive as we'd like. But even in rural Minnesota, as is true for much of rural America, there are lots more of these programs, and so can help supply these health departments. And then maybe you want to add public administration, maybe you want to add accounting or business, because you need those to run health departments as you do other kinds of health organizations. So all this is to say, once you start layering in these other kinds of agencies, you can see why it's good to not just think about schools of public health, and why, as a practical matter, a lot of health departments don't merely employ public health staff because they couldn't if they wanted to. But it's also kind of mathematically, geospatially, this is going to be a complex thing because you have to start to calculate this for every single health department in every single part of the country, which is essentially exactly what we do. So for every health department within, say 50 miles or 150 miles, pick the radius, we need to both figure out who could potentially supply them, but then also account for the fact that it's not independent, right? So if I'm supplying this health department from the school, it's also kind of in competition with the other health departments in the area. You have to kind of account for that weight or that competition. And in urban areas, you might think, well, there's a lot more competition for this single school of public health. So I'm at the University of Minnesota, probably should have led with that. But it's not necessarily true. In rural jurisdictions, you might be like the only game in town competing for a couple rural health departments. And so as we're going to see in a moment or two, it's actually the case that urban, rural, territorial, tribal, everybody's kind of in trouble when it comes to how much availability there is in labor. One of the other things that we do in this project is trying to handle, as I say, this kind of weighted distribution of supply. And so as we do that, one of the nice things we can do as kind of an intermediate step is give this to organizations that might be interested in using that for their own aims. So like ASPPH or ASTO or NACCHO or the big cities, to know who is within that range of distance, to better connect with these organizations for use by internships and pathway programs. So here are the results, and with apologies to those in the back. First, I'll show you public health degree conferrals. So this is really just graduates. You can think of this as a proxy for enrollment, so both useful for internships and graduation. Within 50 miles and 150 miles. And this isn't true graduates, this is after accounting for kind of the competition or the weighted issue. And so kind of counterintuitively, things go down as you go farther out because you're competing against more employers. And so, large jurisdictions, which would include big cities, you have many, many more folks you're competing with, right? Which essentially decreases the effective potential supply. And so in some small jurisdictions, for tribes, for territories, you have very few bachelor's or master's level degrees, even though you might have many potential schools and programs of public health. And again, this is essentially the upper maximum. This isn't, and you're not nearly converting 100%. I think on average, according to ASPPH data, somewhere between 10 and 15% of graduates at the master's level are going into government as their first job. And at the bachelor's level, it's lower than that. So again, take whatever this is and decrease it substantially. So it's a little rough. But then as I was saying at the very beginning, the kind of foundational assumption of all this is that most of our local health departments, especially, and our state health agencies to a lesser extent, really aren't just employing public health educated folks. For better or for worse, even among the younger staff, right? Even among the new hires, though they're much more likely to have a public health degree of some type, it's really in the small minority of new employees. And so as you look at the kind of expanded list of degrees by what folks are most likely to have, and this is what you need to run your agency, right? You need clerical and accounting, you need health informatics, you need Communications and marketing, you need lab, clinical, you name it. And you can put public health in there too, you should. These numbers go way up, right, as you might expect. But now you're competing essentially with everybody for everything, right? So it seems like those numbers should be just fine. But again, when you're competing with the private sector, with healthcare, with government, it's still a pretty bleak situation. And again, I would say for mid-sized, small jurisdictions, for the tribes, for some of the state health agencies even, these numbers are less good than one might think. So the kind of so what of these numbers, numbers are numbers, but for us in looking at this potential labor supply issue, given how many jurisdictions just within public health that are competing for these students, we have such regional variation that we haven't even really talked about too much, but that we know that some regions have far more supply and some have essentially nobody available in public health, but also very few available in accounting or business just by virtue of who happens to be offering programs. So much less for internships, even for graduates. And that can make it very hard to run these programs. And this isn't, a particularly novel concept, right? This is something folks have been dealing with for a very long time, but there's a difference between, anecdotes and being able to prove it with NCES data. So the idea here is if we have two very different kinds of problems, insufficiency of supply versus insufficiency of yield in terms of employees, how do we handle those two very different issues? I would say, if we don't have supply, how do we increase it? And separately, if we have supply but we don't have interest, how do we increase that? And then I also kind of alluded to this issue before, which is we have for so long in public health, and I'll say this, being at an academic institution, a lot of our internship programs forever have been relationship-based. Who do you know at the state health agency or at local health departments? Who do you have good relationships with? Those are great as long as you're there and they are. But if somebody leaves, retires, if the money for that program happens to go away, then it's hard for those students to get placed. And those placements are critical for getting graduates. So we have to create those structures, and they have to be sustained by federal dollars, state dollars, or otherwise. And I know it's easy to say that and impossible to do it, but if we don't, and if we don't have structures, then those things can just evaporate to dust. One of the things I point out, I worked at the Maryland State Department of Health, and I loved it when I was in graduate school, but they couldn't figure out how to employ me, so I got hired through a purchase order. So copiers, paper, JP Leider, right? That was the best that we could do. So it's something I'm always sensitive to. And I'd like to say it's better there since then, but it's not. I think that in the places where you see structures exist, you see the ability to convert fellows into FTEs, you do have better long-term outcomes. But where you have people have to keep applying for jobs, or they don't know how to get a job after they've been an intern, that's where you lose folks. And the other thing I'll say here is that I kind of pointed out that those numbers from before, they kind of represent the numerical upper bound from the National Center for Education Statistics, after accounting for competition among some locals. And we know that some folks are gonna outcompete others, right? State health agencies tend to pay more. Big cities tend to pay more than smaller locals. But overall, we're not competing with the healthcare sector in governmental public health. We're not competing with tech. So it's worth keeping in mind that that upper bound is a little optimistic. I think the last thing I'll point out here is that we're looking to to think next about kind of some of the sociopolitical drivers geographically of why there's such regional variation. So we'll talk about that in the future. But I'll also point out to folks in the room that what we've developed here can really be used for any other process, right? So we've looked at the relationship between, health departments and schools, but it could be hospitals or clinics or whatever. So it's relevant to other kinds of supply calculations. And this is also very useful for fellowships, traineeships, and not just for graduates. So with that, I think we are set. Thanks very much.
That was a great set of presentations. I really thank you all for sharing your important research that you've been doing. And I'm going to take the moderator's perspective and ask the first question, but I'd encourage people to go ahead and come up to the mic, which is over here, if you have any other questions. So, Bianca, you mentioned that in the clinical lab work that having people be exposed to the profession by friends and family was really important. And then we heard from you that that the community colleges were an important avenue. And then we heard from you that females were the important part of diversifying the student body. And all these things are very consistent with other work that I've heard that we've been doing. We've seen a lot of community colleges as being an important part with the PA profession, with medicine. It's not just students that go on to allied health. And then lastly, JP, you talked about structure and the need for structure. And one point of research that I have been constantly wanting to get people to see and how we can build better structure around is getting people into community colleges to show people what those careers are like, to have physicians show up at a community college, talk to students, this is a career, this is how you can get there, and this is what you need to do. Same thing for dentists, same thing for counselors and therapists, and all these other health professions. And so I guess, whenever I mention this, people tend to say, oh yeah, we already do that. But I just feel like there's more that could be done. And so I guess I'm asking for all of you, how can we better make that case for structure? Who should be driving that? Is it a role for HRSA? Is it a role for other health professions? Is it a role for us? How do we get that to happen? Because I think, particularly now in light of the Supreme Court decision, we need to, if we want a diverse workforce, we have to go and look where there is diversity. And half of Black students that enter higher education start in a community college. And I think stats are similar for other diversity. And a lot of white students start in college, community colleges too, but they've also got a different form of diversity, low SES potentially, or come from a rural background. So I just see like so much potential. So how do we fulfill it even more? I guess that's my question to all of you. Who can put structure in? How do we make that case? Any of the above? Anyone want to start?
Well, I don't really have an answer for that. I wish I did, but what I will also say is one thing we should be thinking about is not even just community college, but what are we doing in high schools and pathways even earlier than community college. I think about, I have a high schooler, I think about, what she's exposed to. It's very narrow, and so I think that there's pathway programs that you can bring underrepresented minorities, people from rural backgrounds, you can bring them to campuses and expose them to these things even earlier than community college. So I'm going to think on your question, but I just wanted to put that out there.
Yeah, I guess that's always the pushback I get. It's like, well, it's not just community college, and I should always lead to say this isn't the only avenue. There are other million ways, but to me, the reason why I push so much on community colleges is that they are 2 years away, potentially, from entering higher education. And there's so many gaps in terms of how they can, if they had advice and greater mentorship on which classes they would take that would actually transfer to course credit, or if they were given and connected with jobs that made them more successful applicants, we could really do a lot to diversify health professions writ large. And so I'm just continually frustrated. I'm hoping that someone will have help make that case.
So we have started an undergraduate public health degree at Minnesota. We might be a little bit behind the huge growth curve there, but one of the things that we have done is started as a transfer program. So it's a junior admitting program, not a freshman admitting program just yet. And one of the things that we are doing and expecting is that a lot of our students might come in externally. Right now they're coming in internally, but I think we expect long-term that they'll come in externally, and that we're working with community colleges in the area to kind of set up a transfer curriculum for that purpose.
Great. Structure.
Yeah, other programs in our university have those relationships formalized with community colleges for that explicit reason. I think we could do that more with other health programs generally.
Yeah, I think that's great. I don't want to belabor this, but I'll just make one other case, which is I don't think it always has to be just this formal pathway. How do you get people to just see? Whenever I've done any research on specialty choice, mostly with physicians, but also in other health professions, it's always like, I saw someone I wanted to be. And how do we get people to see who they want to be more and community colleges and open the eyes to all these other health professions? And I don't think it always has to be a formal curricular transfer. I think it can just be maybe a physician has something built into their job expectations that sometimes they will go to a community college and just say, because there's one in every community where there's a medical school, there's a community college. And I think the same is the case for public health. And within like 50 miles of where that health professions program is. So
maybe I could just add a couple other thoughts on that. So, and going to your point that there are more investments in that K through 12 kind of arena, and HRSA being among them, who are providing those area health education center program grants. But you're right, there aren't as many programs that are targeting community colleges to give them the resources that they need, which they are poorly resourced locations. So I think unless we invest more in community colleges and give them the resources to provide that exposure, we do rely on other groups to try to step in, like the federal government, either giving them incentives, or what I think we're seeing in the clinical lab field is with our partnership with the American Society of Clinical Pathology, is that they're bringing together all their kind of peers, all the other professional organizations in the community to say, well, first let's figure out how do people find their ways to these careers, such as what we did in our study, to identify, like, has there been a role for community colleges? Like, has that been a place? Because first we need to figure out, is that a place where people are finding out about their careers? And it's not nearly as much as I think that they had hoped. So then there's an opportunity for those professional societies to come together and think more creatively. How do they leverage their own professional membership to be more present and visible? And so I think to your point, Clese, I think we can do more to try to get professionals brought into these settings in particular to be seen. And I think part of it is what I'm hearing you say is that you'd like to have this exposure at the community college level so that they can move on to something at a higher level of education. But I think it's just as important to give folks in the community college setting a clear sign that there are jobs they can do with their current level of education too. They're well paid and can be appreciated.
Yeah, it's not exclusive. It's just like open all doors to all health professions. Okay, well, I don't want to belabor it anymore. We have another question here, and then we'll go to the one in the chat. Yeah.
Good morning. Yeah. Excellent presentation, everyone. I enjoyed all the presentation. For Bianca, I wanted to ask, are there anything out there in other countries that have maybe created sort of like a mid-level in between pharmacy tech and pharmacy? Like, you know how we have for physicians where you now have physician associates? Are there, templates out there that we can learn from? And for Lisa, I have a question. Did you look at, within MSW, you already have limited diversity, but then did you compare from MSW to even licensed clinical master's social work to see whether there are differences in diversity? And because I know there are differences in the MSWs that take micro versus macro pathways. So, meaning that by the time you get to the clinical ones that are actually doing some of this care, you might even have less diversity. And what can we do about some of the institutional barriers we have? I know recently with social work, I think there was a big issue about the national board exams not being culturally appropriate and them keeping the data, and the data was released and it confirmed what everybody thought. So, what do we do about some of the institutional barriers in the place? And for Simona, one quick question. When you look at the diversity, and my brain was lagging behind your presentation, so I wasn't sure. You also, did you compare like age, practice setting, and hours worked? And what do you think are the implications of this increase in female dentistry workforce for access in rural areas? Because that is one of the areas where we are seeing lack of dentists. But thank you everyone. Excellent presentations.
Before we start to answer, can you introduce yourself and say where you're from? I don't think I caught that.
Shoba, Healthcare Workforce Data Center, Virginia Department of Health Professions.
Thank you. Great.
Great. Well, what a great set of questions,
Yeah.
Yeti. I love your question about what can we learn internationally, and unfortunately, I don't have a good answer for that. But I do think that it's in the work that we're doing on the pharmacy technician workforce, there is a concern about as we try to figure out how to professionalize the degree, which is somewhat controversial, is that it might end up giving us what we call either academic inflation or degree creep, where you start moving the goalpost, right? And we see this in multiple professions, that as we try to think about how to create career ladders, what sometimes I think we may be accidentally doing is that we move the goalpost because we're trying to create a degree that kind of corresponds with that occupation, and then we find new jobs that kind of start emerging and become the next next rung in the ladder, except for the fact that we don't connect the dots between those different rungs. We just keep creating new jobs or new occupations without necessarily saying, well, how does one actually move from one job to another with stackable credentials?
Great. Thank you for all those questions. No, our study did not look at anything beyond master's in terms of going on to get a clinical license, and you raised some of those issues with the disparate rates of passing the licensure exam. If you all haven't seen this, it was really quite shocking. And so clearly there is something wrong with the licensure exam that is hitting on all of this institutional discrimination that is happening. There are institutional barriers that are preventing folks from going on to becoming fully licensed. And I think one policy lever that you could activate would be to think about post-masters fellowships. So we have some mechanisms. The Behavioral Health Workforce Education and Training Grants, for example, have been amazing in trying to expand and make more robust the behavioral health workforce. Those are wonderful, and they provide stipends for master's level students. What could we do at the bachelor's level? But not only that, for folks or schools that have these programs, and we've invested in this behavioral health workforce, what could we do at the next level post-graduation to support them through licensure, to give them the supervision? And one other issue that I'll just raise, which was a little bit off topic, but it's connected. When you are in these behavioral health professions, you have hundreds and hundreds of hours of clinical hours to get as a student. And so if you are already economically disadvantaged, it's very difficult to now have to complete 1,000 hours of free labor. Most of our internships are unpaid. And the same is true with getting licensure. You have to get over 2,000 hours to become a clinical licensed person. So those disparities are making it even harder to get where we want to in terms of diversifying the social work workforce.
So thank you for the question. In terms of if we looked at other variables related to the dentist characteristics such as age or practice patterns or hours worked, including, so in terms of age, yes, we did look, and we did see that actually the income gap was higher, kind of 5 to 10 years after the graduation, but was all along from the graduation and to older age cohorts, but the biggest gap was kind of like, again, 5 to 10 years after graduation from the dental school. In terms of our works, also we found out that, which is consistent with the other literature that was published in terms of female dentists being more likely to work part-time or less hours. In terms of also practice type or setting, also we know that female dentists are more likely to be employed compared to the male dentists that are more likely to own a practice, and all this obviously play a role in the income differences, but all things being equal. After adjusting for every single variable that we had in the data set, and we did have a lot of information that we could address and adjust for, we still found that age gap that was that I showed, that basically 22, male dentists earn 22% more compared to female dentists on average. And also from the decomposition regression analysis, we saw that beyond the explained difference, there is still a difference that cannot be explained by any of the covariates that we had in the regression model. So part could be the things that we didn't have when we didn't measure, for example, specialty, or maybe some other variables related to teamwork, or some other factors that we couldn't measure. But even with that, we know that actually specialty is not very important for dentistry, because 80% of dentists actually are general practitioner dentists. So it's a little bit different from medical, from the physician kind of perspective in terms of distribution of specialties and so on. So again, all being equal, still we did see like a big income disparities by gender, and actually we looked also at race ethnicity. We did see also an intersection of gender and race ethnicity, and we did see also disparity in incomes among racial and ethnic different groups. In terms of rurality, also we looked at the rurality, and we did notice that actually female dentists were less likely to work in rural areas. However, as I mentioned a little bit in kind of my last slide, it's important to take into consideration potential changes in the practice pattern with more female entering the dental workforce, and looking at other kind of strategies to kind of address potential limitations of maldistribution of the dentists, for example, less workforce in the rural areas, as I mentioned, with incentives for dental workforce, or maybe using some new models of care, or teledentistry, telehealth, and some other options and strategies. Thank you.
JP, did you have?
I was not asked a question.
Oh, you weren't? I'm sorry. Okay. Well, then we will go. Didn't mean to highlight that. Sorry. Then we'll go to our online question, and then to Polly.
All right. Thank you, Clese. Yeah, we actually have a couple questions from our remote audience. The first is actually for Simona. Ivy Burgo says, hello from Canada. A question for Simona. What are the implications of these different practice patterns that you've observed, and the gendered racialized factors for dental workforce planning?
So in terms of race ethnicity, the diversification of the dental workforce, in terms of, again, different dimensions, from the gender to race ethnicity to culture to language. So by the way, thank you for the question. And so we have all this dimension of diversification. So in terms of practice, as I mentioned, it's important to look at diversity of patients population, and we know again from the literature that culturally competent workforce can provide more culturally sensitive care for patients of different race, ethnic backgrounds or cultural backgrounds. I'm sorry, second part or first part?
It was just for workforce planning, the overall implications, that's all.
Okay, thank you.
I do have one more question from our remote audience. This is from Catherine from Pitt Medicine. How can we better communicate the value of lab technicians' work to the public and to other healthcare professionals?
And that is very active work going on right now, and ASP is certainly taking the lead on this. They developed a blueprint for action that kind of came out of some work that we did together that really lays out very detailed steps that the profession is trying to take. One of the very first steps, and it seems like a very basic one, is defining the different occupations. There are so many different job titles and so many different pathways to get to these jobs. So one of the first things that's happening is that the field is doing some internal work to make sure that the field in general is all on the same page about what careers we're talking about, so that then when they go out to talk to people, they're all on the same page about what jobs their advertising and how to get to these jobs. So that's kind of the first step. And I certainly encourage folks to check out this Blueprint for Action, and we can try to get that on the website so that people can check it out, because I think it's a really nice model for other professions to think about steps that they can take to highlight certain careers, because I would say there's a lot of common themes that I can see that apply across many professions.
Polly.
So quick question for Bianca and for JP as well. So on the pharmacy side, we know that one of the dangers of relying too much on pharmacies for vaccination during COVID was that they're maldistributed across the country, and that there's increasing concentration of the sort of big chains, which is they're buying out the smaller freestanding pharmacies and closing them. And so, I think that's sort of part of the distress that, and perhaps even the decline in the enrollment of pharmacists, has to do with that issue of the big corporate workplace setting and what that means in terms of access. So I just sort of a question/comment, and I'll go ahead for my JP question as well. So at GW, as you all know, we've worked a lot on the social mission metrics in the context of the Social Mission Alliance, which used to be called the Beyond Flexner Alliance. And we've never worked on the public health workforce. And in your presentation, it was really making me think about two things that I would ask that your team think about. One is the level of responsibility that schools of public health have, and I say this as a member of the GW School of Public Health that has dismal outcomes in terms of the percent of students that actually go to work for local health departments or state health departments. What is our ethical responsibility? And related, and that would be sort of an outcome measure, if you will, of social mission. And relatedly, what can we do in terms of curriculum that we think is really key to improving those outcomes? And where are we failing, sort of as a country, not as a single school, but developing metrics that could put some pressure on schools to do better.
So I'll take that first question. Thank you, Polly, for that question about kind of the changing ownership patterns that we're seeing in pharmacies. And I should probably have clarified that when I'm talking about community pharmacies, it's not like a perfectly agreed upon definition about what makes a community pharmacy. Generally, it's a retail setting, it's out there in the community versus, say, being hospital-based, and there's basically two groups. There are independent pharmacies versus those who are owned maybe by a chain, and I think really the preference when we talk about community pharmacy is thinking about the independent retailers. So I just want to help kind of clarify that a little bit, but there is a lot of concern certainly that that these publicly traded companies are buying up these pharmacies, and then they have different kind of bottom line revenue kind of priorities that are driving the kinds of services, including just dispensing more. That is certainly very stressful to the pharmacists as they're thinking about, like, well, I got 5 years of post graduate training, and all I'm doing is dispensing. And I've heard personal stories too along these lines. There's this frustration that they can do so much more, and certainly the vaccination piece came in as this recognition that, well, these are at least touch points against for patients to get vaccines. But yeah, vaccine dispensing is still kind of still barely scratching the surface of what else pharmacists can do. So I think there's that, again, option. So pharmacy techs could certainly help take on some of that, so we can continue to shift pharmacists to do more of the care practice part, but a lot of that is just so driven by reimbursement. They are just not paid in a way that they can take the time to sit with a patient and give them patient education. And so we have to have a larger conversation about what reimbursement is doing to kind of drive the kind of services pharmacists are doing. It's a complex topic for sure. Thanks. JP?
I really appreciate the question. So I've got an 8-year-old at home, and she's a little young for dating. But I imagine if she came home one day and she showed me a note that said, "Hey, like my crush gave me this," and it says, "How much do you like me? 1, 2, 3, 4, 5." And I'm like a quant person, so maybe I would be tickled by that. But that note is essentially how the U.S. News and World Report rankings work for the schools of public health, and that's it. Can you imagine? That is how all of our rankings work for schools and programs of public health. And I think that people don't appreciate that how much do you like me governs so much of how leadership makes decisions across, are forced to, are incentivized to. And that's not exactly how undergraduate works. It's not how law or medicine works. And even those folks are like pulling out of the rankings because they feel like it is unreasonable and unfair. And so the idea of having things that matter better govern our ranking systems or our mission, boy, does that like sound a lot better than what we have right now. Whether it's a mix of like practical, ethical, it sounds better than, how much do you like me? Check the box. I would like that.
And I forgot to have Polly introduce herself. She's Dr. Pittman, who's the director of the Center Fitzhugh Mullen Institute for Health Workforce Equity. And Fitzhugh Mullen is the person who kind of really drove this whole concept of social mission, so it was a perfect question for you to ask, Polly. Dr. Bazemore, can you introduce yourself?
Sure. Andrew Bazemore with the Center for Professionalism and Value here in DC and American Board of Family Medicine. And thank you for a wonderful panel. It reminded me across all the presentations how poorly our training environment, back to JP's answer to some degree, is set up to really reinforce the need for team-based training and to really make heavy dents in the challenges we face around diversity, inclusion, and distribution in our workforce. And with a House and Senate committee this summer having added to momentum for community-based training, where that really does, to health career pathways and what's working, seem to be working on all of those elements, and particularly advancing opportunities for teaching health centers to be inclusive, more inclusive of dental training, the National Health Service Corps to get more funding for dentists and other professions. I just wondered if anyone on the panel, if not all, might comment on the role and what they see as opportunities for improving community-based training for all your professions.
And I would ask you all to kind of be brief because we got a 5-minute warning a couple minutes ago.
One thing I'll say to that is when we think about, I can use UNC as an example with the FQHCs that surround our campus, it is totally inefficient that we have one person who's working on field placements for social work and another from dentistry, and you can go down the 12 different professions that place students at this FQHC. Why are we not doing this in a coordinated way, and why are we not doing some of those team-based practicums and clinical learning environments coordinated? It's just more efficient for faculty, it's more efficient for staff, and then it exposes that team-based care. So that could be one way where we could, instead of doing siloed practicums, think about partnering up and creating less burden on the agency, constantly asking them to take students from all these different disciplines.
Go ahead. I mean, when I think about the pharmacy workforce, I think one thing to note is that a lot of pharmacy techs are actually trained in the community because they're getting on-the-job training for the most part because they don't have a lot of formalized education. But that does create a stress on, say, pharmacists who have to provide that training. So what can we do to help provide that time and space for pharmacists to maybe play more of that role, or think about other models in which we can provide that training? I think in the clinical lab workforce, they're not as much, say, in the community setting, but I certainly think trying to expose them more to what the community needs are and exploring ways for them to maybe have a more patient-facing opportunities outside of a hospital setting is certainly worth exploring.
In terms of that history also, actually on one of the slides I pointed out to some studies that we conducted in terms of postgraduate residency training, and we did notice that actually when the residencies are happening at the federally qualified health centers or other community health centers, actually there is more likelihood that the trainees will remain in the community for at least several years, being exposed to the type of work and the mission that is uncovered while doing those residencies in the safety net.
I'll say briefly a very positive experience we've had in Minnesota, a pilot that our very own Rachel Schulman started, was able to transition to a school-wide program with the support of CDC money, and now interns are able to essentially get paid practica at our Department of Health and all of our locals. And so hopefully that's able to continue. And now the question kind of is how much are we able to sustain that, but also are there kind of competing interests or brain space for host sites and for preceptors, right? Whether it's with AmeriCorps, whether it's with other placement programs from the CDC or others, right? There's a lot of money right now. And so I think that's like a very, very interesting challenge that we wouldn't have had 5 years ago. So it's not just sustainability of the program, but like, are there preceptors and host sites?
All right, well, I want to thank our panelists for a really wonderful presentation. You generated a lot of good discussion and ideas.
Session 2 is about reducing health workforce turnover in a complex healthcare environment. I am not Michael Dill. Michael Dill was unable to attend. I'm Laura Wagner. I'm a professor in the School of Nursing at University of California, San Francisco. I'm also the Associate Director for Research for the UCSF Healthcare Workforce Research Center in Long-Term Care. And I'm also the founder of the First Gen RN program, which is a career development program for first-generation college nurses. So the session description that we'll be going over today is workforce shortages, burnout, and inadequate wages for some professions, making it increasingly difficult to retain a qualified healthcare workforce. What we're going to do today in this roundtable is to explore strategies to reduce turnover and encourage retention. So we'll have some model examples of that. We'll talk about the pressing issues, what's working, and how can research inform these decisions. We want this to be a very interactive experience after the panelists have spoken, so we're encouraging you to share your insights. While the first period of our first session followed a more traditional academic format, our second session is intended to be a roundtable. It's a discussion of evidence emerging from HRSA-funded studies, and as well as general comments from policy conversations and other types of research. We'll start with brief comments by our panelists. Each will have 10 minutes, so I'll be raising my hand up with a 2-minute warning here. And then most of our time will be spent engaging with you, the audience, and also David will be taking careful notes from our individuals who are online. So thank you, David. We will be addressing turnover in its broadest definition. So looking at entire regions, sectors, and industries, and not just one type of department or organization. Next, I'm going to introduce our panelists today. I'll introduce each of them now, and then we'll go ahead and get started. Dr. Susan Chapman is a professor at the University of California, San Francisco School of Nursing. She's also affiliate faculty within Health Force Center at UCSF and the Philip R. Lee Institute for Health Policy Studies. Dr. Chapman is also the Deputy Director of the UCSF Health Workforce Research Center in Long-Term Care. Next to Dr. Chapman is Erin Fraher. Erin is the Director of the Carolina Health Workforce Research Center at the University of North Carolina at Chapel Hill, and that focuses on emerging health workforce topics. Dr. Fraher is a professor in family medicine at UNC Chapel Hill School of Medicine. Next to Dr. Fraher is Dr. Frogner. We've all met her in session 1. I'll brief it just in case you didn't remember. Dr. Frogner is a professor in the Department of Family Medicine and the School of Medicine at the University of Washington, and the director of the UW Center for Health Workforce Studies, and a principal investigator in the 2 centers focusing on allied health and health equity. And then finally, Polly Pittman is at the end, bringing up the rear here. Dr. Pittman is the Fitzhugh Mullen Professor of Health Workforce Equity at the Milken Institute School of Public Health, and also the director of the Fitzhugh Mullen Institute for Health Workforce Equity. Professor Pittman has an extensive research enterprise focusing on policies that enable the health workforce to better address health equity, including protection of labor rights of health care workers. She is also a medical anthropologist by training. So we're going to go ahead and start with Dr. Chapman.
Thanks, everyone, and welcome to our second session. We're a little different from the first session, as we said, and the big difference is no slides, no screen to look at. But we'll be referring to our notes a little bit, so a little bit more conversational. We were all going to talk about two exemplary studies from our work, but really we're talking about the bigger issues and how these relate to retention and turnover and the various factors related to that. So I'm going to talk about two studies from our Workforce Center, but sort of make the case for how these are broader issues related to turnover. The first study is and this is the title of the study, and if anyone wants the publications, we can get those to you. Some are still in process, but we can get you the detailed references. Also, our studies are on our website, which is healthworkforce@ucsf.edu. Pretty easy to find. So the first study is the relationship between scope of practice laws for task delegation and nurse turnover in home health. So we're going to be talking about turnover related to task delegation and scope of practice and the broader issues there. This was published in JAMDA in August. This was done in partnership with some colleagues at the University of Pennsylvania, Molly Condon and some other colleagues, as well as Joanne Spetz from our center. So how would workforce turnover be related to scope of practice? And for those of you, probably most of you know, but what is scope of practice, briefly? These are the regulations, usually state-based, that say what practice is, how people practice, what they can do, sometimes what they can't do. Again, at the state level, initially, these are meant for a public safety perspective. You know, we're going to protect the public from unscrupulous practice, so to speak. So we're going to protect the public in knowing that what people are practicing is what they're prepared to do and licensed to do. Although, in some cases, this has evolved a little bit to protection of practice. So another thing to think about is as the hierarchy changes in some of these professions, particularly where there are multiple levels, is who can do what and who can't do what in terms of practice. So this particular study looked at nurse delegation. What is nurse delegation? This is in home health, so it's what nurses have to do, what nurses can tell other folks to do, including licensed vocational nurses and nurses' aides. And sometimes it's very detailed, and sometimes it's not. In this study, they looked at this as, you know, could this predict turnover? And so this was a retrospective cross-sectional study between 2016 and 2018. They used HR records from a very large home health registry. It included 1,800 LPNs and also 3,000 RNs, and looked at scope of practice regulations in 30 states. The analytic approach was weighted least squares and delegation as a binary variable. So they took all the 16 parts of practice that could be delegated and sort of said, if you can delegate 14 or more, you can delegate practice. These are things like, can you delegate medication delivery? Can you delegate wound care, ostomy care? Can you delegate other kinds of practices to either an LVN or an aide? The findings, basically, about basic turnover findings, was 30% for LPNs and 37% for RNs, which is pretty high in itself, right? I mean, turnover of a third of the workforce, and this is just without the delegation criteria there. The basic finding, they didn't find a relationship between delegation and turnover for RNs, but they did find it for LPNs. And the bottom line is that LPN states that had the greatest delegation of tasks, in other words, they could delegate more tasks to home health aides, had lower turnover. So what's this about? It's a little bit about autonomy. It's a little bit about practicing at the top of your license and having the person do the skills, provide the care that is at the top of their license. What it means is that what's the impact if you can't delegate, is that nurses do more of these tasks that maybe someone else could do or someone else could do in another state, or that the LPN has to do these tasks and therefore can't do some of the other things they want to do. So autonomy is a big issue here in how people feel about their jobs and turnover, and also this issue of practicing at the top of their license. What policy matters here? It's scope of practice and delegation, and how we make these rules. Again, 30 states, 30 variations, actually 50 states, 50 variations. And why do we have this? How do we determine this? These are state regulatory agencies that determine this. So they set the policy. This is not a lot done at the federal level in terms of state scope of practice and delegation. There are certainly competencies and certifications at the national level. But when it comes down to who can do what and how that's prescribed, it's mostly at the state level. So this is really a matter of working with the professions and the associations in terms of what makes sense in terms of delegation. And there are, if you can imagine, huge levels of disagreement about this, from discomfort, let's say, among nurses. I don't want someone else to be responsible for something that I can't see. I'm not there. I don't know who's doing it. I can't monitor the quality. And also, I don't need to be there. Someone else can do this just fine. I trust them. It's delegated. So in between there's lots of variation. I think what's novel here is thinking about this as a factor related to turnover. Do people leave their job because they're dissatisfied with how they need to practice or how they're required to practice, and not able to work at the top of their preparation and education? So I think it's states, professional licenses, scope of practice, and associations. I better zip onto this next study. Okay. I said I'll never take all the time. Okay, the next study is about turnover in the sense of shortages, turnover leading to shortages, chronic turnover leading to chronic shortages. And this is looking at personal care aides. The paper is, there are three things: a health affairs paper on assessing self-care needs and worker shortages in rural areas. This was done by myself and Laura and some colleagues at the University of Montana. We also did some story maps. This is a sort of a communication policy brief type of thing where there's a story with very short pieces to it and using literal maps or pictures or something. And then we did a photo map, which is a process by which people go and take pictures of their work and then get interviewed in terms of describing their work. So those were the two. It was a mixed method study, and those were our approaches. We used American Community Survey data on self-identified limitations in self-care. We were looking, the big question was, are there enough PCAs in the geographic areas where persons who identified with a self-care disability might need potential care? And then the interviews were with personal care aides that worked in rural areas. Now, we did this during COVID, so the interview process was tough, and we didn't get enough interviewees that we wanted to get. The basic bottom line was that there are not necessarily people in the areas where they are needed. There are a number of maps that show areas of high need but low numbers of workers. There's some concentration in the south, but also other parts of the country. In terms of looking at the PCAs, there was a difference between those working in rural areas and not rural areas. Our focus was rural areas, but we actually ended up looking at the whole country. Personal care aides in rural areas tend to be more white, born in the US, speaking English at home. However, putting the PCAs together as both rural and non-rural, the poverty rate is astounding. 19% live below the poverty line, compared to 7% of the civilian workforce. Implications from the interviews: we have pictures of people showing long roads with no breakdown lanes. We have little little markets that, no supermarkets, nothing, sometimes no internet connectivity. It's lonely work, it's low paid, and lack of recognition. So the policies here, I'll just be another minute, are Medicaid funding, but that's not all we need to solve it, but that's certainly part of it. A whole complicated mess of acronyms, long-term services and supports, home and community-based services, state waivers for who's getting what in terms of home and community-based services. It's a very mixed bag. You need to know who's eligible, who a caretaker can be, who can be paid to be the caretaker, what the income limits are, and then what they can do. So it's a very complex mix of services and policies that we've created in LTSS and HCBS that we could really look at creating some more uniform policies to address. And so that's the federal government, that's states, and also bringing in the workforce for their opinions. Thank you.
All right, good morning all. Welcome to our round rectangle table. Glad to be here talking about this really important topic of retention. I'm going to start with a project that was actually outside of our Health Workforce Research Center work. This was a project that we did with the North Carolina Board of Nursing to project the future supply and demand of nurses in North Carolina, RNs and LPNs. We did that work pre-pandemic, and so we actually have more updated data that we can actually compare how accurate our forecasts were to what the actual numbers in the workforce were, and we did that analysis. And one of the most striking things is that well, I don't know if I said to you that a group of nurses were not in the workforce who we expected to be in the workforce, who do you think they are? And we found out they're actually the nurses' ages sort of about 25 to 50, and they're missing largely from the workforce. Our over 50 workforce, too late to retire, too late to change career. We actually almost perfectly projected that workforce. And so that brings us, mostly when you talk about this missing, I'm talking about nurses, but this missing workforce, and you go to the legislature, what is their first thing they want to do? Open new schools of nursing. And so we actually, and that's important, it absolutely is essential, but our modeling actually showed them that the bang for the buck was much higher if they actually focused on retention. Because if we looked at nurses leaving the workforce 5 years earlier, that forecast was actually much closer to what we would have predicted given historical trends. And that brings me to the fact that if you look at national policy right now, most of the dollars are focused on new entrants. We have $240 million in the Bipartisan Act to increase supply, but we've got to focus on retention as a key thing. And one of the studies, and the reason that's important is if people drop out, nurses drop out at 30, we've lost 30 to 35 years of their career, right? So we've got to work on retention as a key element. And so that brings us to one of the studies that's being done in our Health Workforce Research Center by Tanya Jenkins, who's a medical sociologist. And she is actually looking at the factors driving burnout and presumably exit from the physician workforce. And she's an ethnographer, and she's done about 8 months of observation, 500 hours of observation, 125 interviews. And she's actually trying to explore the synergies between the organizational, societal, and professional pressures that cause physicians to burn out and affects their well-being. And she's been able to tease out organizational factors because she's looking at 3 different clinics. She's been able to tease out professional factors because she's comparing general pediatricians to pediatric surgeons. And she's actually looking at societal effects through clinics in low SES communities versus high SES communities. And she actually will have a paper coming out in Social Science and Medicine called Physicians as Shock Absorbers, a system of structural factors driving burnout and dissatisfaction in medicine. And so this paper really explores these synergies between the reasons that we need to sort of focus on the organizational pressures around productivity, around quality metrics, around scheduling, combined with the professional, pediatrics, you gotta be bubbly. That was the feedback that a lot of people heard, you gotta be bubbly. And you gotta be a superhero. And you gotta, we're trying to balance training people with providing services. And then you've got all sorts of societal pressures happening. And so I want you to just to keep your eye out for that paper. There was another paper that Bianca and I and colleagues did, a New England Journal of Medicine paper, sort of looking at these organizational factors to creating a healthy work environment for nurses. And we're trying to really look at factors affecting inflows of nurses, the working environment, and outflows, and trying to really move from this discussion of drivers of burnout to solutions. And so some of the things that we've talked about and others have talked about already today is matching work with expectations and nurses' expresses need. So getting nurses involved. What do you need from practice? Transition to practice programs, not just for new nurses, but for nurses and others who are changing practice environments. Incentives for preceptors. So I had the pleasure of talking to Ways and Means staff the other day about preceptor tax credits. We've got to deal with preceptor shortages, new models of care. And one of the things that comes across really importantly in this work is the need to really understand during COVID, there were huge efforts made to change the workplace environment, to retain workers. We've got to do an inventory of those efforts and really understand which one of them worked and which didn't, and how we understand the influence not just on retention, but on nurse well-being, patient satisfaction, and patient outcomes. And so one of the things we're trying to do is think about the way that the pandemic was this acute stressor. And so Brianna Lombardi, who's the deputy director of our center, is actually doing a lot of work on workplace violence. So workplace violence existed before the pandemic, but it's become exacerbated and doubled after the pandemic. So she's doing some work with colleagues looking at how workplace violence varies by state, varies by occupation, and then within an occupation, does it vary by setting? And so keep your eye out for some of that work. And it builds on a lit review that's already on our website that sort of looks at the fact, this was just, I mean, it just blows my mind. 14% of all workers are in healthcare, and yet healthcare workers, 75% of injuries are for healthcare workers. They represent 14% of all employees, and yet 75% of all injuries. And yet these are underreported, right? Because to be reported, you have to miss a day of work. You have to miss a day of work. So that number is unreporting the data, and it's not reporting the psychological trauma that is happening with workplace violence. And so one of the things that we're trying to do is collect the data to really understand and benchmark what's out there and drive towards more standardized reporting. And the last study I wanted to share with you is a study that we're doing just this year, trying to deal with the fact that we know in order to increase nursing supply, we've got to address this bottleneck for nursing faculty. And one of the things that Dr. Cheryl Jones identified is, and we know this already, but it's as a framing, a really important framing issue is, how do you become a faculty member? Well, if somebody thinks you're really good at clinical research or you're good at the clinical side of things, and then you become a teacher, but you've never really learned how to do the pedagogy. And so you have people come into becoming a nursing faculty member, and they're not happy because it wasn't the job they expected, and then they exit. So how do we create onboarding programs for nursing faculty, and presumably for other faculty? So she's doing a survey of about 1,000 BSN programs to try to figure out who has these nursing onboarding for faculty programs and the characteristics and lengths of those programs. So those are some of the things that we're looking at across the board: inflows, maintaining a healthy workplace environment, and outflows. So some of the things happening in Carolina. So.
All right. Great, thanks, Erin. So I'm Bianca Frogner. I'm not Davis Patterson, as in the agenda. Davis is COVID affects us all. So I'm channeling his spirit here today, and I do want to acknowledge the great work that he did to contribute to my comments today. So I appreciate that Erin kind of laid out this New England Journal of Medicine paper that we wrote, and I would certainly encourage you all to check out because it provides a nice kind of framework to think about what retention and turnover really is about, with that focus on solutions. And I think the challenge that you'll probably hear across us is that there are many common challenges across many occupations, and turnover is not just a simple concept, and it's something that Jeanette Dill here in the audience from Minnesota and I have done quite a bit of work on, using current population survey data to try to track how much turnover is happening. But I'm going to talk about a couple of studies where we're trying to dig in a little bit further to better understand, like, why is turnover happening and what are some of the levers to try to address some of those challenges. So I'm going to briefly talk about a study about the public health workforce and a study about the emergency medical services workforce. So first, just a couple comments on a study that we have published in the American Journal of Public Health, led by Paula Kett, a research scientist at the Center for Health Workforce Studies, and collaborated with Davis Patterson and Betty Beckemeyer, and our colleagues at the Du Beaumont Foundation, is that we were comparing the different experiences of rural versus urban public health workers, particularly in light of the pandemic and the different experiences there. As kind of JP pointed out, we do have some struggles in the public health workforce, and while he talked a little bit more on the educational side, in this study we talked about and looked at the local health departments and leveraged a data source called PHWINS, which is a great data source that gives a lot of information about staffing in public health settings. And what we saw were that when you compare rural versus urban public health workers, we saw that we had less turnover in our rural environments than we did our urban environments. And to some degree, that has something to do with the local job opportunities that may be available in rural versus urban areas. So a lot of times you can't just take by face value when you see higher or lower turnover rates that it's just then therefore rural is doing better, right? It has something more to do with maybe the context in which they're living in. But among those who left in rural areas, those rural individuals were citing more stress, more bullying, so in other words, workplace violence really mattered, and the sense that they were trying to avoid the situation that kind of comes along with COVID. In other words, these are kind of precursors to PTSD. So the experiences of people leaving these jobs in rural communities was just more exacerbated than those of their urban peers. And some of this was tied to issues around local public trust. I mean, public health was in the spotlight, but they were also the source of information. And in some communities, folks in public health jobs were not welcomed in their communities. So there was an example, a story that was kind of shared in this light, that a public health worker went to their congregation and they were told by the congregation, you are not welcome here. And so they had to leave. So those kinds of stories are particularly concerning. And you realize in this period of time that local boards have a real impact on the resources provided to these local health departments. So depending on the maybe potentially politics or the information that's being given to these communities, that can drive the decisions that these local boards are making. So we do need to pay attention to the role that local boards are playing. We have to think about misinformation and how we can tackle that. So, you know, simple problems to solve. And not simple. And that we also need to make sure that we give our rural public health workers the tools that they need to feel empowered to do the job that they have. So a couple areas that we heard as areas that they needed more support is to figure out how to better use the data that's coming to them and leverage those resources. And they also need more leadership training. And I think that's a common theme in the public health workforce generally, is the need for more public health leadership and training in that area. In terms of the emergency medical services, I'm going to share some results from a report that is published on our center's website. So emergency medical services, you know, they're the ones who are oftentimes responding to those 911 calls. And you know, the EMS workforce is quite varied across the country, much like the public health workforce is. So geographic variability really matters here. And in general, folks who work in the EMS workforce, they're fairly low paid. They rely a lot on volunteers. That in particular in rural areas, they even more so rely on volunteers. And there's something called the rural EMS paradox, in the sense that while there's more volunteers, less resources for EMS, it's the areas that have the greatest need and require so much more longer transportation in order to get to some of the patients here. The low pay oftentimes is tied to reimbursement, surprise, surprise. And the reimbursement that's really provided to EMS providers is for the time that they spend transporting a patient, not the time actually spent with a patient. And so those ideas of a 911, an EMS provider showing up on the scene, they see the person, say, you know, you're fine, you can go on, that is not a reimbursed service because they didn't transport the patient to any place. So we did a series of interviews, and I really should say we, it's really David Patterson and his team and folks at the center who did a lot of the work to do some interviews with 17 experts around the country. These were done in the second half of 2020, so really, again, the height of the pandemic, to better understand kind of what the needs are here. And you know, there was a realization that we need to better prepare folks for the job that they're about to do, because it's a very stressful job. I mean, COVID certainly brought 911 kind of as the kind of first place that a lot of people called to get the care that they needed because everything else was closed. So then EMS providers are the ones responding on the scene. And again, while many of them are volunteers, that therefore people think, well, maybe I'm not going to do this job because it's a quite stressful one. But they're showing up because they care about their community. But we can't just rely on goodwill alone to just assume that people are going to continue doing this work. It became a very much of a burnout job. Again, kind of similar to the stresses of kind of workforce stress because of just the volume of work. But they're seeing a lot of sick people, and then they are also getting sick themselves. And a lot of times these are workers who do not have paid sick leave, so they can't take care of themselves and take the time off that they need from work. Some of the kind of promising models that we're seeing is that there are community paramedics who are, it's kind of a somewhat small but growing group of folks who are often recruited out of 911 services, who are finding themselves in the community providing more non-emergency kind of services, providing potentially some educational services, but it's a different pace altogether. It's a much slower pace. It requires a little bit more patience. You don't necessarily get an immediate kind of completion of the task, so to say. And so, again, one has to make sure that we prepare these workers to know that this is a very different job than maybe being an EMS provider. But many states have been trying to use Medicaid waivers as a way to try to pay for some of these staff, which is a start to the process, but we need to make sure that it's a more sustainable source of care. Community paramedics could be used in a value-based care system if they're connected to hospitals or whatnot as a way to make sure that maybe they're not brought into the hospital, but they're incentivized to actually take care of patients in the community. But in order to make any of and all this happen is to leverage EMS providers to provide more care in the community. We need to make sure that EMS providers are actually at the table for these conversations, because a lot of times we don't see EMS really the EMS workforce to really be considered as part of the healthcare workforce. They are really part of the public safety and the transportation arena. The lead agency for EMS providers is NHTSA, which is the National Highway Transportation Safety Administration. So they're not really well connected to the healthcare environment. So we need to do more to make sure that if we're going to support this workforce who are playing a very critical role in caring for patients potentially in the community, that we also make sure that we think of them as healthcare workers and that we provide them the resources that they need to sustain their roles. So thank you.
Thanks, Bianca, and thanks all the panelists. I think I just want to kick this off with a sort of a plea for elevating the visibility of this issue of turnover, measuring it, reporting it, and holding organizations and policymakers accountable for turnover. It is really a crisis of turnover in our healthcare system. And so over and beyond the solutions that we, sort of the toolbox that's traditional and some of the more structural changes, I think in and of itself, measuring, reporting, and holding folks accountable for turnover is part of the solution to turnover. And I think we need to think about it in the context of payment reform. I think we need to think about it in terms of public reporting, hospital compare, those kinds of measures. Turnover, we need to measure it, we need to look at it. Our center does a lot of work on the primary care workforce, CHCs, the National Health Service Corps, and we have some work on retention in that area. I'm not going to talk about that now, but would invite other colleagues also in the audience who are part of our center to report on some of that work. I'm going to focus in particular on the issue of nursing in hospitals, which is where we have the biggest problem right now in terms of the exodus, as Erin pointed out. I think that there's no mystery as to why nurses say they're leaving. They say they're leaving because of understaffing. We just witnessed the largest healthcare strike in the history of our country. That is what they said the problem was, and that wasn't even majority nurses. We know understaffing is a huge problem. So in one of the few studies that we've had that's focused on hospitals that HRSA has funded, because HRSA largely funds things related to primary care, but because of the crisis with nursing in hospitals, they funded a couple of years of studies in hospitals, was one that asked the basic question of whether what I think we would all assume that understaffing is related to whether or not you have enough money to hire new staff is true. So the question was, do hospital-level resources have any relationship with, in particular, we measure nurse hours per patient day, so nurse staffing and the relationship to patients. And we looked at this before COVID and during COVID, and we found, first of all, that before COVID, there was no relationship. If you are a wealthier hospital, you're not necessarily using those dollars to invest in your nurse staffing. If you're less wealthy, you don't necessarily have fewer dollars to address the staffing issue. So pre-COVID, there was no relationship between hospital resources measured in two ways, days cash on hand, and the other way is the asset relationship between assets and income. I forget the term, but days cash on hand was ultimately the measure that we used throughout the process. And then we looked during COVID. And during phase 1 of COVID, there was this huge increase in staffing. During 2 and 3, there was this huge decrease in staffing. And what was particularly troubling was that during waves 2 and 3, we saw an inverse relationship between days cash on hand and the level of nurse staffing. These were periods when hospitals were receiving a lot of money from FEMA and from provider relief funds. And so the question is, we had all assumed as they asked for money, particularly from states and from the federal government, that this was going to be used to address the staffing crisis. That doesn't seem to be the case, or at least there's no evidence that they used it for staffing, because those that had more money had lower staffing ratios. So this speaks to what one might describe as a structural problem in terms of sort of the perverse incentives that we have in the way we pay hospitals for nurse labor. This is not a new issue. There's been a lot of reflection on this, particularly because nurses are paid as part of room and board in the DRGs, and a lot of discussion, not by me, but by many other people, nurse leaders, about how we need to account for actual hours in that billing system without hopefully raising the cost of care, but without creating the perverse incentive of creating savings by cutting on staffing. So that's in terms of the drivers. A couple of other areas of investigation and reflection, not HRSA funded specifically. One is when you think about sort of the toolbox of solutions that hospitals use, they have a long history of sort of experimenting with policies, and they know what works. For example, we know that tuition reimbursement works and career ladders work. We know that mentorship works and peer support. We see many hospitals doing those things now. We also know that increasing salaries works. We see hospitals doing that now. Telework, telesupervision, telementoring has been working. There's another set of policies, however, in that toolbox that you might think of as sort of the sticks, of the first group being the carrots. And the sticks have become particularly prominent and long recently. And so, the sort of latest innovation is to create these contracts that have what are called trap clauses, which are training repayment agreement provisions in which orientation suddenly becomes kind of a cost that nurses have to repay if they don't complete a 2 or 3 year contract. And this is spreading across the country. It's become a big issue for labor unions that are upset about the essentially holding people in place against their will through these debts. This is a practice that we've seen over decades in the international recruitment of nurses, but had not been used for domestic nurses yet, and is being used. And sort of a similar approach that we're seeing with large health systems is to create nursing schools within the healthcare system and subsidizing the tuition in return for a certain number of years of service. And those also create a situation where you are creating a debt that you're holding over the employee and to force them to stay. This is also something that I think our local entrepreneurs have learned from abroad. India has been a leader in this practice of debt bondage. They often have their nursing schools within hospitals and a certain number of years that are required. And there's been a huge effort in the courts in India to establish this as sort of labor trafficking. And in fact, they've won, and they've now made it illegal in India. But here in the United States, it's just getting started, and it's particularly popular among the for-profit health systems. The other kind of, I don't know if it's going to be a stick or a carrot yet, but something that is really emerging in the labor market is what some people have called the gig economy. Tony Yang and I and a colleague have a piece out in Health Affairs Forefront just sort of describing the challenges of health systems beginning to move nurses from the W-2 employee status to the 1099 sort of freelance kind of status. This has taken off in the context of the high cost of travel nursing, and so the innovation was, of course, to create your own travel nurse company, but actually they're really just per diem nurses that float. Now, the good side of it is that it's creating more flexible staffing opportunities, and there are all kinds of apps and technology around this. But the idea is there's an app, and you can kind of sign up for your shift, and it gives you more flexibility if you're a mom or a daughter or have other kinds of responsibilities or needs or wants, and it gives particularly young nurses more ability to work the time and the place they need to work. That's certainly a positive in terms of flexibility that could help with retention. What's happening also, however, is that the per diem nurses are losing their benefits by becoming 1099s. And like the issue of the trap clauses, this is an area where our laws are not yet catching up with the business practices. And so there's a lot of discussion in state legislatures as well as in the federal government about how to handle these emerging practices that are more on the stick side of strategies and solutions than the carrot side. So those are areas that we're watching, and I think, again, accountability for turnover is where we should all be focused.
All right, as I said before, this is meant to be a very interactive session. And again, for our in-person audience, we would like you to go to the microphone over here on my left and ask your questions. And for our streaming audience, please use the Ask a Question tab. And David's very excited over here, so I guess people are already putting questions in. So why don't you start us off?
All right, thank you, Laura. First off, we have a question from Hari Sharma from the University of Iowa. This is for Susan. Can you talk a little bit about...
Tell her hi.
All right. Can you talk a little bit about the differences observed between RNs and LPNs/LVNs? What might be driving the difference? Is there any qualitative data on these?
Not related to long-term care, just broadly. We actually, long ago, did some studies on LPNs. As many of you know, there's an education difference, and there are huge scopes of practice differences. So the education is, it's part of that career ladder in some ways, although it's also a career in itself. LPNs generally a year to maybe 18 months education. Lately, a lot of education taken over by the private schools, so paying a lot of money for these degrees. And the practice is regulated by states and heavily regulated by states. We did another study on this years ago on LPN scope of practice, quite varied by state in terms of what's laid out in terms of what they can do and what they can't do. And also the difference between nurses and LVNs is more apparent in some regulations than others. An interesting anecdote about that is when California went to mandated staffing ratios, nurse-to-patient ratios, they specifically didn't define nurses. So the whole question of what LVNs can do was part of the question. And the nurses, this actually became kind of a fight between the LPNs and the nurses in terms of these ratios, basically forcing a lot of LVNs out of the hospital because they couldn't do some of the higher level skills in terms that allowed them to take full responsibility for a patient. LPNs are often found in long-term care facilities as the key nursing component. However, when we just recently saw the CMS regulations about staffing in long-term care facilities, the LPN component was missing. We're not sure what this means. Mm-hmm. But there are differences, I think, mostly education differences for sure, shorter education time, but also very much related to what they're allowed to do and not allowed to do, and who regulates that. And again, this hierarchical thing about who defines, practice protection, so to speak. So that's the short,
right,
that's the long answer to that.
The short and long answer, I suppose.
So we're going to take an in-person question, and we'll come back to you. And please introduce yourself and where you're from.
My name is Jeanette Dill. I'm from the University of Minnesota, and I have 2 questions, so feel free to just answer one if it's too much. But Polly, one of my thoughts when you were talking about the relationship between staffing and financing within hospitals is whether or not you had looked at the role of unions and if they play a role in protecting staffing ratios for nurses. So I would love if you could speak to that. And then, and I guess what prompted that question too is I just got an email this morning about physicians at one of the major systems in Minnesota going up for a union vote on Friday. So it's not just nurses that are unionizing now. And then Erin, I was just reading one of your papers from a long time ago about the nursing supply in North Carolina and how it very rapidly switched from a shortage to a surplus during the Great Recession. And so I would love if you would talk more about the way that the healthcare workforce interacts with the economy.
So the question, so it would be logical that unions would advocate for better staffing and that they might include that in their contracts, their bargaining. And in fact, we see that more and more the issue of staffing ratios are being included. They didn't include them in the past. In general, I think labor unions thought that their role was to advocate for state-level guardrails around nurse-to-patient ratios. Of course, California being the first state, and many other states now considering the same, and it's driven by labor unions. But they realize now, I think, increasingly that they need to do that in the process of collective bargaining. So it would make sense that it would reduce turnover. I do not think we have data on that, in part because we don't have hospital-level data on unionization. But SEIU does, and I've been asking them for that data for a while. It'd be interesting to look. As a proxy, we have looked at the level of right-to-work states versus states that don't have that legislation, and we don't see, just with HA data, and we don't see any significant difference. I mean, one of the things about labor unions that I've been thinking about in the last few days in the context of the Kaiser strike is that in some ways, once people are organized, their expectations of the working conditions are elevated. And so, paradoxically, or just like any kind of satisfaction survey, sometimes you have lower satisfaction if your expectations are higher, and you also have the ability to voice your complaints where you might not otherwise. Mm-hmm. But you would think that it would make sense, but no. As far as I know, there is no data on that nationally.
All right, thanks, Jeanette. I feel like I'm at my comps now trying to remember a paper. I'm gonna do my best. I'll start by saying that paper, I believe, was really drawing on some great work done by Bearhouse, Steger, and Auerbach, which really looked at the way that nursing supply really is responsive to the economy. And so in times of recession, more nurses stay in the workforce, and at times when it heats up, they exit. And I think that still at a national level is really important. I want to go back to the backcasting work that we've been doing, sort of looking at where our projections were on and where they were off. One of the things we not only dug into age distribution, we dug into geographic distribution. So where did our model do a good job and where did our model not do such a great job? And one of the things as you see, and we're beginning to just tease this out right now, it looks like the places where actually there were more nurses than we predicted were places that were urban with hospitals and resources. And so what I think, one of the things, and this is really early work, this is a work in progress thing for us, is sort of to tease out the fact that one of the things you see during a stressor on supply is that the have-nots end up doing worse and the have-wells do well. And you end up with an increasing disparity because the people with hospitals can pay more, they can attract more, they can have more packages, whereas the more rural places that have hospital margins that are much lower are probably a lot more nurses in long-term care. And one of the things our model is showing is a whole chunk of nurses missing from long-term care. And that's because of work that Bianca and others have done sort of tracking employment. You can see that long-term care is still, employment in long-term care is still not recovered from where it was. And so I think your point is really well taken. I just want to sort of drill down from that really seminal work by Berhaus, Steger, and Auerbach to say, I think we also need to think geographically in our communities about places that have the ability to be resilient to these shocks and places that are less resilient. And I think we need to think about more about the organizational factors within those counties and wage differentials, for example, that may be driving those differences. The last thing I want to say that we're dealing with in North Carolina is maybe, and I know other states are as well, the unfortunate thing about the healthcare workforce is when there's a shortage or when there's a perceived shortage is because we have no National Health Workforce Commission. We have no planning. We don't do workforce planning. It's not very American. And so what you end up is with a lot of individual groups reacting very quickly in a fragmented way. And so you end up with the market overcompensating. And so you see we have this nice graphic that we show is sort of this overcompensation from supply, if I had a paper lurching from oversupply to shortage, and that really is this thing about, so what the policy intervention here is to have some sort of more coordinated policy structure at the state or federal level that actually uses data to make informed decisions. So.
Great question. I have a question for oh, yeah, we've coordinated already. Okay. So, Erin, you mentioned in your talk, and I just wanted to highlight this, there's an issue right now in training around we can't get enough preceptors, and so that's one of the problems. And so you mentioned preceptor tax credits, and I know there's at least a few states, Georgia and Hawaii, that come to mind about these tax credits, and I'm just wondering if you can share a little bit more about your knowledge about these tax credits, and maybe somebody in the audience, might go back and we can expand that as an offering.
And my knowledge is not deep. It goes, but basically there are a significant, so Georgia was one of the first, but there are a significant number of states at the state level that are using state-based tax credits for preceptors to really increase the incentives to become and remain a preceptor. And so I think there may also be national tax credits that could be given. We're sort of just trying to figure out what are the levers that are out there for changing the incentives that are out there in terms of having our availability of preceptors. So that's about my knowledge. It's really about that thing.
Okay, it's just a good point. David.
Yes, thank you. Yeah, there's actually several remote questions coming in. But here's one. This one's from Renee Fulton from the Washington State Workforce Board. As a person who works in state health workforce policy, I understand retention is key, and yet oftentimes find myself at a loss at what policy levers to pull, given that so many of these factors are driven by private employers. Mm-hmm. Do you have any recommendations for those working in government policy about how to impact retention? And also, one other question, and to Patricia, to Polly, I should say. How do we make turnover a publicly available piece of information? What would that look like?
Well, the National Council of State Legislatures would be a forum in which these kinds of reporting requirements could be established by law. You could also require it through CMS and the credentialing of facilities. There are all kinds of things that are reported from healthcare facilities now, and they're reported publicly. Some are used for payment, some are not. But there's no reason that we couldn't be reporting turnover. First, we have to establish a methodology for measuring turnover, so we're not, everyone's not reporting in different ways, and you can actually aggregate the data. But I think that the answer to the first part of the question is what can the boards do is to report it and hold employers accountable. And if the turnover is really high, and they could be benchmarked against each other. I mean, obviously there are external factors that are driving turnover as well. Not the least of which are things like violence from the community. But you can benchmark across similar organizations and provide incentives, either positive or negative, in your policy toolbox to say, we're watching. And you have a lot of power to actually make the working conditions better.
Susan?
I just wanted to add, you can make it a quality measure. Jaco can be at the table, and the other.
Jaco said no, but someone else might.
But maybe they'll say yes in the future. But it is impact quality directly. So why do we measure it? Why don't we use it as a quality measure?
Yeah, I'll just add to that. I think a lot of the work that we tend to do as researchers is we identify a lot of the problems, but I think this helps to identify, what are the sources of turnover so that we can figure out then what is it that we're asking to collect and report, and I do think that states have that opportunity to do so. And I would just add to, among the metrics, I would love for us to add not just turnover, but some of the precursors to turnover that we know seem to affect this are having access to health insurance and having things like paid sick leave. And we just don't really have very good state-level data, or let alone employer-level data that's reported publicly on what kind of insurance do we give to our healthcare workers that would allow them to go get the care that they need, like mental health care. What kind of number of days of paid sick leave do we have? And these are precursors to losing our workers. So can we then create metrics as quality metrics, just like we do for patient reporting, that tells us something about the workplace conditions of these workers?
Yep. Yeah. Just to follow up on that, Bianca, we did a study here at UCSF where we saw this huge disparity between hospital workers and long-term care workers and their benefits. And so we need to think about the disparities as well, because that's another issue with turnover.
Yeah, I think often by producing data and putting it out there, we can change behavior. And so I'm a simple believer in actually collecting and disseminating data, because in this case, if we lower the information costs for an individual person trying to figure out where to work, and there are places that are known to have lower turnover, they're going to be the places where people want to go work. Mm-hmm. And so just simply having the data and putting it out there, I wish that would work in graduate medical education, but that's a whole separate panel.
Well, if I can just add, I do know Renee over at the Workforce Board in the state of Washington, and I think that they're quite an exemplar in terms of every state has a Workforce Board. They're funded out of the Department of Labor. They're funded through the Workforce Investment Opportunities Act. But not all workforce boards in all states take the active role of focusing and prioritizing healthcare workers. And so I think a lot of other states could certainly take a page from at least what I see in Washington State, where they play a very important convening role, bringing together stakeholders around the state to have conversations about how to strengthen that workforce.
Clese?
Hi, I wanted to talk with you because particularly when you asked the question about tax credits for precepting, the state of Ohio has been investing for precepting training by giving community health centers up to $50,000 for precepting abilities. And what's nice is on the data front, Erin, is that they actually track who is providing the training, how many hours, and which students got it for how many hours in which setting, and are showing retention in those settings, so that's great. But my question for you all is related to talking to a lot of community health centers recently. They're really struggling with salaries and how they can pay, and they're turning to other avenues for recruiting and attracting the existing workforce, like offering telehealth or telework benefits. And also focusing on addressing diversity, equity, and inclusion in their environment. And I was wondering if you've heard any other things in any of your research that are along those lines that aren't necessarily salary, but like work schedule flexibility and things, and what effect that has on burnout and retention.
I certainly think we could all say pay matters, but pay also is not just as simple as wages. I think what you indicate there are benefits also that we have to think about, total compensation. But leadership matters a lot. The work environment really matters, and that
tends to be kind of dovetailed with the leadership. So I think we can certainly do more to make the work environment a more welcoming place, but also a place, as I mentioned earlier, a place where people feel recognized for the work that they're contributing to. And some of that is recognizing, like for nurses and hospitals, and others can speak to this more, is getting them beyond a line item in a budget, or as JP said in the public health workforce section, saying that he's a purchase order. I mean, that doesn't make anyone feel good when you realize like maybe you're not a valued employee. It sends that kind of signal.
Yeah, and go ahead.
You go. I'm still thinking.
I keep thinking. We've been giving a lot of thought about segmenting these interventions across the life course of a career. And so let me be more specific. What you would need to retain a younger worker who's just entered the workforce may actually be wages. It may be they're still on mom and dad's insurance because they're under 26, so give me that money, please. I don't need the health insurance. And by the way, I want a flexible schedule. And then you move into sort of the mid-career where maybe I still want a flexible schedule. I might want some childcare supports. I might want some housing supports. Housing is a huge issue, housing supports. I might actually want some role flexibility. Now I'm maturing in my career because I might want to move from the clinical stuff into a different role. And then I might need an onboarding program that actually helps me make that transition, as well as some leadership. Wages might still be important. And then transitioning into my later life where I'm really tired from being at the bedside. It's a hard job. I might want to transition to do telehealth, telework. And so we've been trying to sort of segment this across the life course to really understand sort of which interventions at which point in a career and how do we support those. And to your point, some of those could be actually legislated. So tax credits, housing credits, things like that could happen through state appropriations, through 1115B waiver, which are being used for all sorts of interesting things. So I think there are avenues out there, and one of the things we need to be really specific about is which of those are state levers and which are federal levers. And I do think the organizational piece is hard, but there are levers that we can use.
And just to say that we actually have a HRSA project funded this year. Samantha, who's a postdoc at our center, and Candace Chen, who's back there that everybody knows, and I are working on, it's a combo lit review on retention and / sort of solutions to burnout, moral injury, and then including the retention literature, which of course is much more historic and robust than the literature on solutions to moral injury and burnout. But one of the things, and combined with key informant interviews with folks we hope that are sort of the high burnout and the low burnout end of the spectrum on the HRSA survey that they did on burnout, and we're still talking to folks about whether or not we can actually get that purposely diverse sample. But at any rate, we'll be interviewing them. The reason that things might be really different in CHCs in terms of burnout and moral injury, and particularly in terms of moral injury, of course, is because it is a safety net setting with a lot of social mission. And so it's really interesting to compare CHCs to other kinds of even primary care settings that have been bought up by private equity, and understand how different the pressures are. Not to say there aren't pressures in CHCs, but they probably have more to do with issues around, we imagine, limited resources, and less around the sense that there are unethical reasons that are impeding their practice from the leadership. But we don't really know. So anyway, that's a project that has just been launched.
David?
I wanted.
Oh, you wanted to? Okay, come on.
I wanted to add to that a little bit in a different frame a little bit. Because in long-term care, we know about turnover. 100% sometimes per year, nurses leaving in droves. It's about the job, right? Work in isolation, fewer colleagues around, lack of respect, recognition, a director who's not interested in the bottom line and profitability and not necessarily about the care. So let's look at the jobs, too. One of our studies of medical assistants, who some of you might know are the person who might take you to the exam room, take your blood pressure, leave, and you never see them again until they check you out. We've done a lot of work on how to change that role to increase involvement, part of the team, making them part of the team, showing respect, recognition. Tell me what you saw, tell me your thoughts about this, and actually expand your role and train you for an expanded role. So let's look at the jobs and the job quality and what people say about their jobs, what they like, what they don't like, what they'd like to do. And I think that's where the private sector the private employers, if they want to keep people, pay attention to those surveys and what people are saying about their jobs.
Great. David?
Yes, thank you. Ivy from Canada has another question. First a comment, then a question. First of all, she 100% agrees in the shift in focus from recruitment to retention. And her question is, are there any systems that are working on returning workers who have left?
I know there's a lot, anecdotally, not scientifically, but there's a lot of conversation around one of the sort of more enlightened things that hospitals can do is to not be angry at the nurses that left and went to work for travel companies, and to invite them to come back. And I've heard anecdotally of a few health systems that have done that proactively. And that it's been, they touted it is very successful. That's the only example I know of.
Yeah, I mean, the only thing I think of also is like during the pandemic, as we tried to get the increase in supply of workers that we needed to respond, an approach was trying to relax some of the requirements to get recertified, to come back into the workforce. And that did seem to work, but we don't have a lot of quantitative data. I would say it's just qualitatively, it sounded like it worked well. And I have been thinking a lot about what does it mean to bring somebody back in who may have left for some years. Is that a recruitment or a retention piece? I actually realized I was not so sure about that. This kind of topic came up yesterday, and I've been pondering it, because when you're recruiting back somebody who was formerly in the workforce, but it's been some years, is that retention or recruitment? So it's like a chicken and egg question, I guess. And I asked that partly because the kind of data that I've been using with Jeanette, looking at turnover, which is like current population survey data, gives you kind of a short time span where you can follow somebody from a monthly basis, sometimes over a course of a year, to kind of see their job changes. But we don't have very many other data sources that allow us to follow somebody's life career to see how things have changed over time. We've done some work using the panel survey of income dynamics, which is another national survey. It does follow the same persons over multiple years. And we did see among folks who were in these personal care and home care aid kind of positions that we found these people called swirlers, is what we call them, because they kind of left their jobs, came back in, left their jobs, came back in. To some degree, I was a little bit worried that there's a measurement problem about how we code some of these jobs, like were we consistently calling them the same thing every time that they responded to the survey. But it did signify that there were a number of people cycling in and out of some of, especially these lower wage, lower skilled as defined by education level requirement to get into these jobs, especially when I think about the economy question that Jeanette asked, is that in some of these jobs that have low barriers to entry with regards to education, people do pop in and out of healthcare and then other jobs in the retail sector. And so when the economy isn't doing great, much like what you see with nurses, other healthcare jobs see a swell of workers who come into these jobs. But then when when the rest of the economy is doing better, McDonald's, Walgreens, Walmart, Amazon, they are very effective at recruiting people because now they have the resources. People are buying things again. They have the money to pass on to higher wages and higher benefits to these workers and recruit them away from healthcare.
I think flexibility is another issue. When you're trying to get someone back, how flexible can you be about when they work, how they work, what they do? And, sometimes, particularly hospitals, can be more flexible than they are.
I agree. I just want to add, thank you, Ivy, for the question. I think it's really important. We have thanks to Tony Kane and some folks in our office at SHEPS, created longitudinal files of nurses and physicians. So we actually are beginning to try to apply life course methods to really understand who is entering and exiting over time and where they're going. And one of the things I want to highlight is that re-entry may not be back to a hospital. It may be to an outpatient setting. So one of the HRSA-funded studies that we did last year was looking at primary care careers. We used latent class analysis for data in 2005 and 2019, and we looked at whether you could sort primary care physicians into careers, and in fact you could. And in both periods you could sort them into 4 careers, a rural career, an urban, ambulatory and urban hospital career, and then there was a group that was actually providing maternity care services. And these careers were stable between 2005 and 2019. And the next analysis that we hope to do is to look at whether people during their life course actually change careers. So this is really critical to understanding what we need to do to support people's careers in the long run, and it may be allowing them to have a different career, and that still counts as retention.
Yeah, comment about that, and Polly brought this up earlier, is we have all these tuition remission programs, mentoring, residency programs, and those are primarily focused in the hospital. But as you say, Erin, we have all these FQHCs, nursing homes, home care, rural settings that don't benefit from that level of support. So I don't know if anyone wanted to comment on that.
I think this is an area where HRSA could play a role in terms of helping to transition folks that might otherwise be lost to healthcare. In particular, we're losing all these nurses from acute care settings. We thought back in 2010 with the accountable care law that the nurses were going to move to primary care. It didn't happen. Would they stay in healthcare if there were good jobs in primary care? What role could HRSA play in doing sort of transitions within healthcare kinds of residencies or support systems? I think it is a role that goes beyond the private sector.
Great. We have a question in the audience. If you could introduce yourself before.
Aloha, I'm Halaiwalu Wakalahi. I'm the president and CEO of the Council on Social Work Education. Thank you again. This has been really, really wonderful and informative. So I'm going to just think out loud for a minute. So we're here today because we're worried about the diversified workforce, number one. Number two, building on a question that was asked previously in the first session about communities. That is, I think that is our goal, is to build healthier communities. And I wonder about turnover, recruitment, and retention, and how we are tracking. If we're focusing on retention, those that are, the jobs or individuals that are leaving the health professions, is that impacting our diversified workforce? Mm-hmm. Do we know that in data? As Erin keeps saying, look at the data. Or is that anecdotal? And for me, I'm a Pacific Islander woman, and we're not even on the tick list, in terms of check which one you are. It's aggregated, and so I think about the disaggregated data on this turnover and how is that impacting our diversified workforce efforts. That's number one. So just want your thoughts on that. The second one is this idea of goodwill. I know, Bianca, you brought that up, and I really truly believe that for a small community like mine, that is the only gold you got, because you're committed to your community. So you're going to stay in there despite the hostile environment in the workplace, despite the low salary. I wonder if there are studies that could leverage that kind of power. I know you're not guilting nobody to stay in healthcare, but in a small community, especially in rural communities, sometimes that's all you have. So how do you incentivize that? How do you nurture and cultivate that? So just thinking out loud and wanting to see what your thoughts are.
Those are wonderful questions. Thank you so much for that. I do want to, I guess, let folks know that we have a study, again, that using the current population survey, which I keep plugging, which is wonderful, really. The Bureau of Labor Statistics funds that survey, and it's a very robust one. But in that study, we do have some work where we're looking at the changing racial diversity of the healthcare workforce pre and post the pandemic. Again, the work that I did with Jeanette, we do see that there were higher levels of leaving among folks who were Black or Latina, but we didn't add the incoming part to see, are we also seeing a slowdown in those who are coming into these jobs? In addition, we will be using the National Sample Survey of Registered Nurses. Thank you very much, HRSA. And we're looking forward to the 2022 data, and we will be comparing that to the 2018 data to see how the racial and ethnic diversity has changed among registered nurses over this time period. But I do want to note also and acknowledge the challenge that you're mentioning, which is that getting some granularity on some of these groups is really difficult. I did some work with folks at GW, really led by folks there, who looked at a breakdown of the Hispanic and Latina workforce. And I say Latina because there's so many women in healthcare. It's a very female-dominated field, and for that by itself, we should probably feel pretty proud about it, but we should make sure that we're making sure that women have opportunities at all levels of education and pay. But the key thing about the paper with the folks at GW that's published in Health Affairs is that it shows that we have to acknowledge there are many different ethnicities within the Latina workforce. Cuban Americans are different than Mexican American, and they have different experiences. And when we lump them all together, we're losing some of that granularity. And it's a difficult thing because even in some of these national surveys, which have fairly big sample sizes, we are stuck constantly aggregating things back up, because when you start slicing and dicing things even further by gender and then by age and all that, it's a challenge. I don't have a good solution for that.
I know that in community health centers, Candace, you can help me out here, but one of the grantees on the Burnout Project is a community health center network in Texas. And they had done a survey of burnout among all of the healthcare workers. This was separate from the HRSA surveys, but then also looking at turnover or quit rates. And it was much higher among young women, no surprise there during COVID because obviously they had children who were not in school, but also of people of color. Right, Candace? I remember her telling me this, but it's not published. Hopefully it'll get published, but it's a network of CHCs in Texas.
I just wanted to add a little bit about the rural piece. I think we need to do more to recognize how rural work is different and the challenges in rural work. The incentives may need to be different. For example, in our study, these workers were driving an hour and a half between clients sometimes. Are you going to pay that for that time? It should be work time, but not everybody pays for it. So we don't recognize enough the unique factors that are particular to the rural workforce in terms of incentives and also, what we need to do to retain.
And if I can just address the question about the goodwill part, since I did mention that, and I kind of put it in the context of those who are volunteers in the EMS profession, I would say the same for those who are in very low-wage jobs. Oftentimes when I look at the long-term care environment, I think, who takes on these jobs? These are such hard jobs, especially those home health aides who are going into people's homes, dealing with some of those most intimate moments with people. Like, that is a person that cares, and that's great that we got those people there. How do we keep them? And I think in a lot of ways we have just been relying on goodwill, and like you said, because people feel some sense of like, this is their community, these are people that they care about. But I think in a lot of ways COVID, I don't want to say destroyed some of it, but I think it certainly pushed people to say, it really tested them to say, okay, no, I need to take care of myself first. And I think this is why in the economy broadly, we are seeing a low return of people coming back to the workforce generally. I mean, we talk about shortages here, but I think most other industries are also struggling with this same challenge.
David?
There are some measures of that.
Yeah, of will.
I stay in my job. There's a normative measure, which I feel like I owe this to the community.
David?
All right, thank you. And we do still have several questions from our remote audience, and we're not going to be able to get to all of them. So much like the first panel, I'll distribute these to you afterwards.
Okay.
With
we
that
have
said,
some time still.
Yes, there are. Y'all are going to need to be fast. Okay, our next question is from Jordan Heron from George Washington University. This question is for everyone. It regards burnout. How much do you think non-medical school issues among patients contribute to provider burnout and turnover? Some facilities try to aggressively address these issues, but could broader social policies addressing social needs of patients have a positive impact on burnout and turnover in the health workforce?
Yes.
Yes, and especially
Next question.
In safety net settings. Stay tuned for the CHC study. That's the hypothesis, right? Is that it's really about patient need.
So Dr. Jenkins' work that will come out in Social Science and Medicine actually addresses this because she, so keep an eye out, Jordan. She is comparing well-being, dissatisfaction, and burnout in low SES versus high SES areas. And one of the things that she sees is part of what's burning the pediatric workforce out is in the low SES
neighborhoods is this feeling that they can never address all of the needs of their patient population. And so it's really absolutely spot on to say that's where her model of sort of it's not just professional and organizational, it's also societal. And so when we look at CMS's new payment policies to sort of support payment for addressing social risk and social need, one could hypothesize that perhaps if there's participation in those codes and in taking that reimbursement, that being able to address some of those things through community health workers or through other types of healthcare workers could potentially take the load off of others on the team, primary care physicians and nurses. But that presumes, when we haven't talked about the role of teams in burnout, and one of the studies that show, you don't want to just take the burnout off of one member of the team and shift it to the other. So that's a whole other conversation, Jordan, but I think it's a good question.
If I can just build on the teamwork part of it, I do think that some of what we see about burnout among physicians and nurses is also driven by the fact that a lot of the folks who support them, we're seeing much higher turnover among them versus the nurses and physicians, but we don't hear about as much about what that means then for the work burden that we're seeing among physicians and nurses who have to take that on when others leave. So I think thinking about it from a team environment is important. But from a social point of view, I think certainly as a country, the temperature has been high, right? And that this translates to some of that workplace violence as patients come into these settings, or even workers come to settings where they're upset about things that are happening in the world. And so it's a big issue that does go beyond probably what an employer can do.
Yeah. Okay, we have a question in the audience. If you could introduce yourself.
Good morning, my name is Steve Holloway, and I work in Colorado in the primary care office. We administer about 1,000 contracts out of our office that promote and incentivize recruitment, retention in the state. And I've noticed over the last 2 to 3 years that moral injury seems to be the most common theme from troubled contracts. So I suspect it's not only an important contributor, it's a growing contributor to the challenges we have with turnover. So I certainly reflect on the comments and agree with the comments made up to this point. My question is that as a resource allocator in government, I feel it's my job to sort of determine what are the characteristics of employers that successfully retain and what are the characteristics of employers who do not. And I think moral injury is a pretty important theme. So I wonder if you could describe for us what are the things that we should be looking for from a policy standpoint so that we're disincentivizing the kinds of practices that don't work and incentivizing the practices that do. And then maybe I'll have a little follow-up question, but I'll leave it at that.
Thank you.
Are we allowed to call on someone in the audience? Right behind you is Dr. Candice Chen, who's, so she and I co-PI a big project on moral injury, but she's also obviously an expert on primary care. I know you have a great answer here. Since you won't be able to ask a question, you can answer a question.
It's like a game show.
Hanging. So I do have something to say about the previous comment. One of the things that Polly is sharing is that we were also lucky enough to be awarded a technical assistance center about addressing health worker burnout, and we've added moral injury to it because we really think that moral injury is something different, and the evidence suggests that moral injury is something different than burnout, and that what people are experiencing isn't fully captured when you call it burnout, and that the solutions don't fully address the issue if you just consider it emotional exhaustion, depersonalization, the things that go along with burnout. What about the anger that is going along with that? And not to plug something that we have fingers crossed is going to be coming out later this month, but we're about to release a website, an interactive website that both helps to reframe the issue with incorporating moral injury, but also very quickly tries to turn people towards what are the solutions. And I will start, when you think about policy making, I kind of come back to Polly, right? Like, what are the things that externally will drive organizations to look for the solutions that actually work? And I think that the measurement really does matter, right? And we've talked about maybe creating a well-being measure. Maybe not, we like turnover, we like staffing, but maybe creating that very first well-being measure, and sometimes you get that immediate response of, oh my gosh, there's so many quality measures, one more burden, right? But that would be the first one that would really be about the well-being of workers, right? And the incentive the external incentive is a little bit different. And then when we start digging into what works and doesn't work, there's a lot of things. We've started conceptualizing it in what we call operational. So it is the staffing, it is the EHR, it is the administrative burden, it is the violence, the physical safety, the mental health, the stress trauma. All of those things are really, really important, as well as the reward and recognition. You talked about leave, right? Protecting people's leave. But we also have been really thinking about those relational areas, and there's evidence for this, right? Participative leadership styles, governance, and I know the nurses in here are going to recognize this word, the shared governance, but true, authentic shared governance, we'll say, right? And accountability around that, protecting workers to be able to speak up and have voice. And what the website hopes to do is to provide you a little bit of evidence, and I'm going to be honest, there's going to be lots of places where you're like, where's the evidence? We couldn't find it either. But we're hoping that is the place where people will then start to, it sounds like Erin, Bianca, I mean, that you guys are already digging into those places, right? And so we're working on it, and hopefully very soon it will be available to all of you. If I could just share, and Debbie Goldberg over there is one of the grantees, but on the thing that you were talking about, we basically support 44 grantees. 2 of them are large community health center systems. One is based out of New York and working in Puerto Rico. One is in is San Ysidro, which is in the Southern California area. And I think maybe what you were thinking about is we had the opportunity to review and read 43 out of the 44 proposals which the grantees shared with us. And probably what I was sharing with Polly is that what really struck me out of the community health centers is the fact that they were thinking about things like, what's the average wage of my workers, right? And what are the other social determinants of my workers? Erin, you talked about childcare, right? But what about food insecurity, right? What about living in fair wages? And we have another grantee, Northeast Oregon Network, that works specifically with unlicensed workers. And so there are people out there who see it and are trying to work on it, but there's a lot of external policies that are going to drive whether they can do that or not.
Thank you. Thanks for coming in and rescuing Polly there.
Teams.
And I think the 2 of you might talk at lunch, maybe. We'll see. David.
Yes, I guess we're almost about time, but perhaps one more question. I think we can get another one in. This is from Catherine Kennedy from Providence VA Medical Center. Her question relates to what workforce research may be going on as it relates to staffing in assisted living or residential care settings, which may or may not have licensed nurses on staff. This group of healthcare workers has largely been omitted, but the population of older adults in assisted living is almost 1 million today.
I'll start, but then I'm going to toss it to Laura because this is related to some recent work we just got. We've been trying to study assisted living from a workforce perspective for a long time, but since it doesn't necessarily fall in the healthcare arena, it's kind of hard to look at, but it's such a big piece of, and one of our upcoming projects is on assisted living, but we also have this big new grant to look at assisted living and staffing. And Laura, I'm turning it over to you because I'm sure you can add a lot to this.
Yeah, so we just got a $80 million U54 grant. University of Michigan's going to be the PI on this. And it's called the Dementia Workforce Study, and it's going to be a longitudinal study. And we are going to be surveying assisted living because it certainly is an area of untapped resources. There is some work in North Carolina that's being done in this area, but for the large part, it's very difficult to get into these settings. I think the lobbyists control a lot of the message, the facilities control that. So I just think it's such an untapped setting that we need to do a lot more work in. And if we can get assisted living providers to allow us as researchers to come in and help study and help move the science forward in this area, I think it can only benefit the care of the residents in that setting. All right. Any final quick questions, or we have 1 more minute? You said you had a whole pile of questions there.
Okay, here's a quick one. To go off the preceptor tax credits, this is from Allison Turner, MU Healthcare. off the top of your head, which states in the USA currently utilize this? I am in Missouri, I believe, and have never thought of this.
That's why I mentioned it.
I'm going to call, this is my turn to call a friend. And I'm calling my friend from NCSL.
You want to come up to the mic?
Do you want to say what NCSL is?
The National Council of State Legislatures.
Hi, I'm Kelsey George from the National Conference of State Legislatures. And we do have a list of states that currently have preceptor tax credits. So if you would like that, you can come see me. But we are working on putting out more resources on that topic and graduate medical education and clinical training generally.
And is there an email that the participants who are on the webinar, because they're not,
Or a website?
or a website?
Yes, if you go to ncsl.org, you should be able to find or reach out to me through there.
Well, we're going to be breaking for lunch now. The streaming will be ending at this time. And so I would really like to thank our audience who were on live, on the streaming audience. I would like to thank you for joining us today.